Hi, everybody. We're going to go right into things. We're not going to waste any time because this is going to be a very full 2 days. But I want to welcome everybody who has joined us today. Um, this is going to be probably unlike anything you've ever been a part of, um, uh, in part because it's a virtual, super interactive event, and in part because this is very global, very multidisciplinary, and intentionally so. This came out of a group discussion at the WHN where what are we going to do? How are we going to make things better? And we created this event. And so um, I want to start by acknowledging that throughout the world, uh, and in particular in the U.S., and maybe especially because it's the U.S. Of what's happening in the U.S., it's these are really hard times, and the uh, the people I think right now are overwhelmed with what to do. There are so many disasters happening, whether it's erosion of civil rights, the climate crisis, ongoing measles transmission in places that normally don't have measles transmission, and of course, COVID simmering in the background, including some worrisome signs coming out of Far East Asia that there's a new variant that's starting to rip through. So what do we do? How do you even try to approach a global uh, polycrisis like this? And I think the answer is you got to focus. You've got to like put your head down and say, I can't change everything, but maybe I can change this one little thing so that the world is a better place. And let's be fair, like when we say one little thing, like this is the worst pandemic in the last the COVID was the worst pandemic in the last 100 and some years, killing millions of people. And it was actually relatively small, 1% of mortality rate. I'm not going to neglect to talk about the long COVID morbidity that's come from this as well. But you can imagine that if we got a 5% or 10% mortality rate event, that would be just much more of an impact than what we've already experienced, and yet we're not prepared. Um, to be fair, we do know what works, right? I think right now the science of airborne transmission is well defined. It's understandable. We actually know what we need to do. The problem is that it hasn't been implemented, and that's really, I think, the key to this event that's coming up is we're not trying to define what to do. We're trying to define how to figure out why this was never implemented and how to fix that. Um, so it's pretty clear to me that we have not won. Um, we've won, I think, the science, all the major global public health groups have acknowledged that it's airborne, but we still have um, multiple challenges in getting this implemented. Um, we still have contact droplet precautions in my hospital for all respiratory illnesses, and no evidence that they want to talk about changing that. In my own country of Canada, the Public Health Agency of Canada, they still can't say the word airborne. They basically use the term um, uh, a transmission that floats through the air like smoke. For some reason, the word airborne is not allowed. They do recommend N95 like masks, but they can't say the word N95 or respirator mask. They have to say well constructed, well fitting masks, which don't describe anything other than a respirator mask. And I don't understand this. And I'm hoping that by the end of the next 2 days, we understand why such things are in place and how to fix that. And for me personally, we um, I want to get out of this with a plan, with some kind of concrete. Here are the 5 steps that we're going to do. Here are the people that are going to do those steps to try and reverse the situation that we're in. And maybe we should have done this 4.5 years ago. Maybe we should have done it 2 years ago. But great we're doing it now. At least we're getting it done. Let me start by introducing everybody that's in the crew that's been involved in this. My name is Dr. Joe Vipond. I'm an emerge doc in Calgary, Alberta. And I don't really have any fancy titles behind my name. I am literally just emergency trained. But I have been involved in a lot of campaigns in the past. And so that's kind of how I've gotten here as an advocate, both on working on climate mitigation and then COVID as COVID came through. We have three team members from the WHN, the World Health Network. We have Frank, who has been super helpful in organizing all of our facilitators and our moderators to do the best that we can do. And Sharon and Katie, who've been kind of the workhorses back here, making things like this incredible logo, making sure our Zoom meeting runs. And I just want to highlight Katie Marsh, just remember that name, Katie Marsh, because Katie is our problem solver. She's our fixer. So that if there's a problem, if you can't get audio or you aren't in the small group session that you want to be in, you can reach out to her and she'll help you through. Katie, maybe you can put your email address in the chat just so that everybody has that. We also have a core group of organizers. We've been meeting every single week for, I don't know, what has it been, 6 months now? Spella Salomon, based out of Austria, Julia Wright, based out of Dalhousie University in Halifax, Mark Ungren, based out of the University of Calgary, and Professor Sunil Raina out of India. And so thanks to everybody who's been really key to making this work. I want to go over a few ground rules because this is going to be a bit chaotic, right? Like we're going to have the small group sessions in particular. We're going to be asking people to be stepping up. This is not a passive event. This is an event that we really want interaction. So the first rule is we know life happens. People have childcare duties, or they have ill people at home, or they have the time zones in particular worth drawing attention to. That some people are either 6 in the morning right now or in the middle of the night right now, and so I acknowledge the challenges of that. If you have to go to bed, if this is too hard, that's fine. Participate in as much as you can, but the key is to participate, because the more we can interact and get things done, the more we'll get done. And really, it's that what we're striving for is that interaction of brains, that interaction of multidisciplinary, and to take us forward. The second big rule is that we want to point out is Chatham House rules. Unless we have your permission, we will not be sharing anything from these discussions. We want you to feel completely able to say whatever you want, criticize whoever you want without attribution. If we do go forward to doing whether it's written, peer-reviewed piece, or some kind of media event or a webinar, we will make sure that we get your permission to share your views or your image and voice. So we will be recording a lot of these sessions, but we were asked that you do not record on your material. And if you do want to get involved in some of the writing and have access to all of this, we can certainly make that happen. Next rule is share the mic. We do have everybody here is super smart and everybody here has a lot to say. But we only have a finite amount of time. So we as facilitators and moderators during this event are going to make specific efforts to include everybody, so that if somebody is over speaking, please don't take offense if we step in and say, that's great, appreciate your views. We do want to get some other views out there. We also want to make sure that everybody's positive when they're chatting. We're brainstorming, and one of the key rules for brainstorming is that there are no bad answers. Near the end, we're going to have to make some decisions, and those decisions, we want people to advocate strongly for. Uh, but but during the small group sessions, let's be supportive of each other. Let's not get into any major battles. Um, our intent is to get as many people from across the world as possible. I do want to acknowledge that there are some glaring issues. Our network does not have a lot of people out in the Far East, the Global South. Africa, in particular, is underrepresented here. I also want to acknowledge we're overrepresented by the United States of America and by Canada, just due to the networks that the organizers have. But these are things that we need to work on fixing for future events and um, for other convening. So we're acknowledging that in advance. We can think about how to fix that going forward. The other thing we're missing is I don't think we have all the disciplines here that we want. I really wanted to get an economist into this event, and we were unable to secure an economist to be a part of this. And we can debate as to the role of economists, but I do think they have an incredible role in figuring out numbers and the invisible hand that pushes the world forward. We're going to try and really make an effort to keep to schedule. It is a very tight schedule. In particular, our panel discussions are very short. That is actually intentional. Um, the uh, the way that the 2 days are organized is very intentional in that day, this first half day is going to be a series of short panel discussions to try and get us all kind of with some shared understanding of some of the problems that we're approaching, so that when we get into the discussions, we actually have that kind of shared basis where we can and talk forward from that. Um, we have some incredible speakers that are going to be presenting at the panel discussion, but I also want to acknowledge that we could have had any one of you in these panel discussions, and we had to make some tough choices as to who was going to be here. Um, After those panel discussions, we're going to take a short break for lunch, and then we're going to go into our first set of small group sessions. The small group sessions have two purposes: to try and maybe get a deeper understanding of what went wrong for the first half. So that's the obstacles, looking back at obstacles and trying to have a really good understanding of why we failed as a society. And that's to set up the next day, which is to acknowledging that we failed as a society to deal with this problem. How do we fix this? And so, what are the concrete things we can go forward? And those will be those next small groups discussions. I also want to acknowledge that during those small group discussions, that this is a time to get to meet each other. I have not met the vast majority of people that are attending this, and I want to meet every single one of you. And we've made a real effort to try and mix it up so that you're not in the same 6 or 7 people with each group. Hopefully, you're going to meet a whole bunch of new brains over the next 2 days. And so a big part of those small group discussions is getting to know who everybody is and why they're exceptional at what they do. And then in the last half day, we're going to actually make those concrete decisions. Okay, these are the 200 things that we can come up with that we want to move forward on. And how are we going to narrow that down to 4 or 5 concrete things that we can actually enact as a small group of 50 people? So I hear somebody's unmuted there. Katie, can you figure out who that is and mute them up? All right. So look at that. We're trying to keep the schedule. We're right at 7:15. I'm just going to say one more thing. During the breaks, there's going to be some bathroom breaks. There's going to be some lunch breaks. We're going to keep the rooms open so that both the breakout groups and the main room, so that you can actually chat. You can have side conversations. And then we'll figure out at the end how we're going to share people's information if they want their email address shared. And then That's it. That's the end of our introduction. It's quarter after the hour wherever you are, and we're going to go right into it with our first panel discussion. This is a historical look at the how we got here, and this is going to be led by Julia Wright with our speakers Jose Jimenez and I hope I'm pronouncing this right, Isolet Jones. Over to you three.
Morning, everyone, and welcome. So I spoke to the speakers in advance, and we're going to go in the order on the program. So, Jose, over to you.
Yeah. 1 second, I was just getting out of bed and making coffee. Yeah, so, and I think I understand you wanted this to be quite brief. So my summary of the historical aspects, which I got interested in it during the pandemic because I just could never make sense of why the WHO panel was so closed and just so certain about that they were right and that this disease was not airborne when on the face of accumulating evidence that we were seeing, the Quire case and many other cases. So, and some of the people, I was new to this subject with the pandemic. I hadn't worked on airborne transmission before. And some of the people like Don Milton and others that had been working on airborne transmission for a long time, that that it was just due to some old history and this fellow Chapin and whatever, and that didn't make any sense to me. It's like, well, yeah, there is old history, but science gets renewed when you have new evidence. So I started pulling threads of it during the pandemic, and finally compose this arc of the history, kind of we wrote an article about that with many people who are probably here. But the short version is, during most of human history, humanity believed, since the Greeks, or the West believed, I should say, that airborne transmission was, or some version of airborne transmission with miasma, this is coming through the air, was very important for epidemic diseases. When a lot of people got the same disease, it was probably going through the air because that's what we share the most. That was, I'm paraphrasing Hippocrates. And then that basically stayed, I mean, there was a lot of debate, a lot of things, but that stayed the dominant theory till germ theory until the 1850s. And in the 1850s, John Snow shows that cholera was through water. And then Semmelweis shows that another disease goes through the hands. And then later it's shown that malaria goes through mosquitoes. And there is a debate around 1900, basically a period of debate about, well, this airborne transmission that we thought was important, maybe it is still important for tuberculosis or for some diseases, or maybe it was just a superstition all along. And Charles Chapin, which is an American epidemiologist in 1910, comes along and writes a book and summarizes the evidence. And without having any proof, he just says, airborne transmission was a superstition. Let's get rid of it and finally be relieved of this specter that has, made us afraid all these centuries. And basically, he's too successful. The profession really likes this and accepts it. And when, for example, after World War II, the CDC is established in the US, the person who's in charge of the epidemiology branch refers to Charles Chapin as the best American epidemiologist. And basically, they all follow his footsteps. And it is really, when we think about a disease like measles, that's so clearly airborne transmission, it was only around 85 that's finally accepted, so many, many years after World War II and all that. And so we, in that period, we're in a situation in which, well, when it becomes absolutely obvious, it's admitted as little as possible. But the underlying cultural frame in these professions is that really, for a disease to be airborne is very, very difficult, and basically based on this history and in these beliefs and that's where we are when COVID starts. Basically, we're still reading some of these writings from 1910 from Charles Chapin. Now I was going back to our meeting with WHO in April 2020, and it's like, well, it's like if the guy was alive and was in the room, they were saying the same thing, you know. So it's not everything, as we know. There is many other factors of that we will talk, I'm sure, about during the day. But I think it was important that that really, there was a cultural frame that these professions were embedded into, in which they were just so certain, and they didn't even remember necessarily why, but they were certain that this was the case, that airborne transmission was just very difficult, and it was just too unlikely, and this disease was not like measles, so it wasn't airborne. And they were forgetting. I mean, it was never very logical. They were forgetting, for example, that tuberculosis is a disease that's much slower transmitting than COVID. Yet, and it's known to be basically pulmonary tuberculosis is only airborne, but but somehow they were pointing at measles and forgetting about tuberculosis. And anyway, so let me leave it there, and we can continue to
Thank
talk if
you.
there are questions.
Great, thank you. Over to you, Ezolt. I think you're muted. Oh, you're still muted. Oh. It flicked off for a
I've
second.
just
There,
asked you.
That.
there
Yeah,
you
is that good? Okay. I was clicking on it. It wasn't unmuting, but now we're good.
Yeah.
Um, I really enjoyed, Jose, reading your historical perspective on these issues. And you're a good storyteller, so I was really, sort of drawn back into some of the illustrative examples that you give about the barriers that are facing new scientific interpretations in history. Cholera is probably the easiest one for people to latch on to. The delay in accepting the conclusions from John Snow's research about the waterborne nature of cholera. And I think too that the barriers that we're seeing in the acceptance of ideas of airborne transmission, which I actually didn't know until I read that piece, how long they persisted into the 20th century. But in some sense, maybe we can think of these things as sort of predictable, given the barriers to new modes of thinking, and in particular barriers to thinking about transmission being airborne. Um, I think it's also true that as historians, we only come to understand breakthroughs in the history of disease after the fact. So we don't, if we're not living through them. I mean, the pandemic was odd in that way, like a sense of crisis, a sense of sort of wanting to listen to public health and not being as critical as they might have been if it was a historical context. Anxiety, panic, all of these things intervene for people who are living through disease crises at the time. The urge to certainty, I think, is also an emotional thing. And we know too that not every new insight is going to turn out to be correct. So there are, these kinds of reasons that we maybe are conservative. I think there's other social and cultural reasons that you highlight, and I think are important. Innovative scientists historically are often newcomers or outliers or outsiders in some way, who lack the cultural and political sort of star power and resources behind them, compared to those people who are sort of setting the culture of causation. We think of people like Pasteur or Robert Koch, who had major resources behind them, the two main promoters of germ theory. So history of disease also is also looking all the time for heroes, right? Usually these are white men. And that also, history itself provides this way of reifying existing modes of thought because of its, sort of persistent attention to certain kinds of heroes. So in the long history of disease, change is not frequently rapid, I think. Change takes time. Even the acceptance of germ theory itself is not a story of an overnight shift in paradigms. It took many decades for it to displace earlier ways of thinking about disease. And maybe it might not have become as ascendant as it was or as dominant as it became, except for the historical context out of which it emerges. Germ theory, industrial capitalism, and kind of the height of the imperial era, they all have intersecting histories. And in a general sense, the focus of public health moved from broad strokes of sanitationism, which was expensive, sanitary change, expensive, and ideas about social change, for example, ideas about more social equality that was necessary to improve the health of workers. The shift from away from that toward microbe hunting and tracking down the individual vector is kind of consistent with the needs of industrial capital. And that trope is still very, very powerful even till today. The idea of the public health detective who can find patient zero and stop a catastrophe, that paradigm still makes sense well through the 20th century. In a world that, in a basic sense, is really driven by the need to avoid large-scale social transformations and to combat movements that focus on things like the safety of the workplace or the adequacy of wages and housing or the rights of Indigenous people to their land and to their healing traditions. So in some ways, things that are pushing against the dominant paradigm in the 20th century are also things that are promoting a kind of agenda that in some eyes is, sort of a socialist or a socialized agenda, which is not the end goal of capital. So the idea of a more specific droplet as a disease carrier, I think, is more easily it more easily facilitates public health to identify culprits and not causes. So contact and contagion are still fundamental elements for public health. So we can see this in things like screening immigrants, which isn't really about disease control as much as it is managing the labor force. Making sure people are aware that they can't become burdens on the state, identifying people who don't conform to public health messaging. The goal is to let cheap labor move around the world while conveying really quite powerful ideas about the role of the individual in staying healthy and productive. And over time, the gospel of germs, of course, becomes internalized in Anglo-American cultures. It was the backbone of every woman's duty in the home, cleanliness. So in a hierarchical world, I think disease carriers were people who were already othered. The people who were seen as carrying disease were the poor, people of color. And since the early 20th century, public health has mostly operated on the imperative to change individual behavior and to define entire groups of people as incapable of changing their behavior, and so sort of situating them outside of modern ways of life. And this goes, toward justifying discrimination or colonial subjugation in various places all over the world. So I think changing paradigms requires, yes, significant cultural change well beyond science. And it requires networks and relationships that can compete with a dominant paradigm, which is why I think gatherings like this are really interesting to think about. How do we create new networks, new modes of human connection to share and promote knowledge? How can we alter the balance of power relations in public health? And how can we sort of actively negotiate a relationship between experts, but also beyond the boundaries of science into the inclusion of the public itself? So I think the lesson of the past is, as Jose has identified, about that importance of broader cultural change and whether or not it happens, right? If it doesn't happen, then that's for worse. But if it can happen, then that's better. Thanks.
Great, thank you. Thank you both for very interesting presentations to get us started today. Are there any questions from the audience? Anything anyone wants to add? Okay, well, if anyone has any thoughts, please feel free to raise your hand. I
I
wanted
think
to pull
Dr. Curran has a hand up.
Oh, okay, great.
Also, we have Clive Beggs in queue.
I very much enjoyed those first two introductions, but there's something for me about we're being a bit nice on the WHO here. We were in an era of evidence-based medicine. We were in an era of how to produce guidance critically, how to critically analyze. And they didn't. They had resources trained to critically analyze the literature. And the literature, when you look at it, stares you in the face. So there's something there that didn't work. And I think we need to kind of find that out. I understand all of the historical, but the whole healthcare organization moved and they didn't move. Sorry.
Jose?
If I may, yeah, nice to see you, Yvonne. Yeah, I mean, if I react to that, I mean, I agree. I mean, I think the history still had set us up, but had someone else been in charge of WHO, they could have broken forward. But the particular people who were there were not visionaries at the top and were really not honest scientists, the people who were in the committee, you know, John Conley's committee that was deciding how the disease was transmitted. But history helped them in the sense that it made it easy for their professions to help them with something they didn't want to do. And of course, all the things we just heard about the economic system was more than happy to continue to to avoid the consequences of this. But yeah, I think that was really sad, and it's really sad that the same people are still there. And I mean, I think, and I reached out during the pandemic, tried to talk to people. There were people inside WHO who were understanding what's going on and wanted to change things, but they were not the ones that were in charge. And I want to single out Maria van Kerkhove as a particularly resisting figure that really didn't help. So I do think that's. I mean, we were unlucky. I mean, the leadership changes, or I don't know. I don't know WHO. I don't know if the leadership is always like that. But these particular people just didn't rise to the top, to the moment.
Great, thank you. Clive Beggs?
Thanks. Just one point, really, which I felt quite strongly for a long time and hasn't come out in the kind of literature a lot. A lot of people have pointed out that it's the kind of idea that gets in first. So hand washing, for example, but obviously droplets was thought about early in the 20th century. And the problem is statistics actually doesn't help us. And one of the problems with randomized controlled trials, or any trial, you've got to decide an a priori null hypothesis, and then you try to disprove that with frequentist stats anyway. And the situation is that these things got in. So droplets was the kind of null hypothesis. It didn't need to be proved. It was, in fact, it was rather difficult to prove. So when they had any trials after that, when they looked at the epidemiological evidence, they couldn't disprove it. So it became very much fixed there. So you say there's no evidence to disprove the null hypothesis, but in fact, no one actually tried to prove the null hypothesis. So that the fact that it got in first, I think that's one of the biggest problems that we've got with our the way kind of evidence-based medicine is sorted out. Rather than maybe if we took a more Bayesian approach, it might have changed. And I think I'll leave it at that. Just wanted to raise it.
Great, thank you. Lydia Morosky?
Hello. I'll be speaking in the next panel and have lots of comments, but I'll just focus on one aspect. We are talking about the WHO and the role of the WHO. I worked with the WHO for the past 25 years or so. We are a WHO collaborating center, but not in this area. We worked on airborne particles from other sources than infectious particles. And I must say that this experience working with the teams in Bonn, with the teams in Geneva, was always the most kind of professionally thrilling. It was always science was the first. There was never a situation in large group, interdisciplinary group, that science was rejected. So it was to me a huge shock and surprise that this particular arm of the WHO reacted to the issue like this. So it's something fundamentally wrong, which I would say, not with the whole organization, but with this specific arm of the WHO. Why? I don't have an explanation to this, but just wanted to share this comment for now. Thank you.
Thank you. Joe?
Yeah, I'm curious. We've already started on a little bit of the WHO as a boogeyman narrative, and I want to be cautious about that. Maybe I'd ask Dr. Jones, because it's not like, as you've pointed out, this has historically been hard to make these transitions. There seem to be factors beyond this. If it was one or two people that were the cause of this problem, the fact that most of those people have been rotated out of their positions of power, and people like Jeremy Farrar, who have avowedly said that COVID is airborne, and yet nothing's changed, right? Like, so I'm curious as if this is strictly a problem with one or two people being bad eggs, then it's easily solved. But I worry that maybe the factors are more complex than that. So, Dr. Jones, do you have any thoughts looking back at other historical events?
I'm a historian of the influenza pandemic, where a lot of people, of course, didn't have answers. They had some answers, but they also didn't agree with each other. I think even in a very technologically sophisticated world like the context of COVID, where we have evidence-based medicine, you have a lot, when it gets to applying it to public health, you have a lot of people who are, you still have paradigms, right? Evidence-based means you have a lot of evidence. Scientists and public health still come to that evidence with a paradigm of some sort. And I don't mean to sound conspiratorial, but I think all I can do as a historian is talk about that broader context and talk about the various interests at play when you talk about public health responses. I can't really speak to the WHO. I mean, I hope that a historian it can look at the discussions of the WHO in the future and try and evaluate what those kinds of interests were. I also wanted to point out that from history, this was something that I was thinking about before. Historically, people can hold competing ideas about disease causation in their heads at the same time. So to say that there's miasma over here, germ theory over here, et cetera, I always teach my students that that's not really the way people think in the real world. So it's quite possible that people are thinking about both droplet and airborne at the same time, and that it gets messy and blurry, and that the pressures of a real world situation cause a certain kind of error in logic or judgment, and that we can identify retroactively. But I think these are all within the idea that we do all come to what we do with paradigms. I don't know enough about paradigms at the WHO to really speak specifically to those, but they're shared viewpoints, I guess I would say, among groups.
Yeah, and I would just add briefly to that one of those shared viewpoints is blaming other populations for disease. In Europe, this goes back 1,000 years. Immigrant groups were blamed for poisoning wells as an explanation for an outbreak of disease. So this is deeply embedded in European culture in various ways. But I see that you've got some hands up. I do want to mention to people we've got just 5 more minutes. So Jeffrey Gordon, please.
Yes, I'll be brief. I want to build on what Professor Jones said and expand it. I conceive of the playing field as a bunch of Venn diagrams, and we successfully deal with the pandemic when they intersect. But if you look at the different factors, you not only have the science of medicine, you have the profession of medicine and its culture, you have the population and its culture, you have capitalism, as she mentioned, and its culture, and you also have politics with a small p and its culture. And the way these factors interact to produce paradigms of consensus, if you will, uh, creates the situation of whether you deal successfully or unsuccessfully with the situation. And I certainly have case studies in the United States, for instance, the meatpacking situation in the CDC and the president, which clearly say that capitalist incentives trump lives in a very, very vivid fashion. And I think that's a small paradigm of what happened on a worldwide basis. So I would promote the idea that we have to step outside the culture of medicine to look at political economy to understand this situation.
All right, thank you. I believe Lisa Brousseau was next.
Yes, I just wanted to actually follow on Dr. Gordon's comments that I do think it's important to look beyond medicine, but I will also say that Dr. Moroska is quite right. It really is actually just one area of medicine that is sort of holding the torch, so to speak, for droplets. And I don't mean to malign anybody who's an infection control or prevention person in this group. But for 25 or 30 years, most of my career, I tried very hard to get the aerosol transmission perspective into all sorts of aspects of healthcare and influenza pandemic planning, and was unsuccessful, just as we were during the COVID pandemic. And WHO was a leader in being recalcitrant in accepting that. But I would suggest that going back to the recent history of TB as a result of HIV in the United States and elsewhere in the world is worth looking at, simply because it replicates and it demonstrates what will happen when paradigms have to shift. And TB wasn't a disease. Yes, it's an airborne disease, but it wasn't a disease that people wore respirators for until there were transmissions to healthcare workers, correction officers, and others from TB patients. And OSHA stepped in the United States. And the world changed a lot for medicine at that moment. And the world changed again during the bloodborne pathogens standard. So it is actually possible to change behavior in medicine and perspectives and paradigms, but it's not easy by any means.
Thank you. So we just have another minute or so. So I wonder if our two panelists have any final thoughts. Ezel, do you want to go first?
Sorry, I thought I had my hand up.
Oh,
Sorry, Barry, we're just tight for time, so we're going to have lots of time to discuss in the small groups.
I don't, yeah, it's such an interesting discussion. And often a place where a historian meets people who have been on the ground and in the trenches trying to persuade a paradigm shift is interesting learning experience for me. I mean, I do believe also that paradigms are changeable, and they do change, right? We know that from history, they do change. Some of them are more powerful than others for larger reasons outside of science, which I think is really where we started at the beginning.
great. Thank you. Jose?
You say that I'm enjoying this discussion, and the real historian in the room. I'm just an amateur historian. And yeah, I used to say that, I mean, I spent much of the pandemic thinking about this. Why are they so resistant and whatever? And I like this explanation of or this way to say it with the multiple Venn diagrams, that really there are many factors and the history happened and the people who were there that were resistant were important, but it wasn't the only thing. If politicians had wanted to go forward, they would have overruled these WHO people. So there are a number of factors why that. During the pandemic, I remember talking to Lydia Moraska and thinking, one day, in July 2020, the dam is going to burst and everybody's going to accept airborne transmission. I kept naively thinking that was going to happen, and that never happened. And I think there were a series of interlocking, interests that were keeping that from happening, and they still are. And that's kind of what we're talking about. Anyway, thank you.
Thank you. Well, thank you, everyone, for a very lively start to our 2 days. And now over to the next panel.
All right, so I'm going to introduce our moderator and the panelists. And before you start launching, if you could just self-introduce yourself with a brief introduction. So Dr. Solomon will be our moderator here today, and our three speakers are Dr. Lydia Moraska, Dr. Mark Ungren, and Dr. David Tomlinson. Over to you, Spella.
Hello, everyone. It's great to be part of this event. I'm not going to waste any time because we have all seen how quickly one of these sessions is over. This session is going to be about science, and I have been involved with the scientific process for a couple of years now. I'm a nuclear medicine physician, but I'm also a molecular geneticist. I did my PhD in complex disease or degenerative disease genetics. Very complex topics. We're not going to talk about that, but we're going to talk about the process of science, what went wrong, what could go better, and what has been defining our performance during this ongoing pandemic. And even though language or communication is another topic, not the topic for right now, I would still like to give a little reminder. I have heard a few people talk about the pandemic in the past tense. I know it's tempting because it's like kind of a everyday thing that happens around us. People say, yeah, that was back during the pandemic, or during the pandemic we did that and that, as opposed to now, not during the pandemic, right? Which is, of course, not true. We are during the pandemic. So I will talk about the pandemic in past, not past tense, but past perfect. So it has been during the pandemic, which is going on, or is during the pandemic. So that's my preference. I think everyone else can do whatever they want, but I'm strongly encourage everyone to discuss the pandemic in the present tense, because that's where we are, right? So I would like to introduce the other members of this panel, the speakers, right? So let's see, we have from the top to the bottom, Lydia Morawska is the first one. So please, Lydia Morawska, if you can give us your introduction.
Thank you very much for inviting me and for giving me a voice in this discussion. My activity, my scientific research on science of airborne particles from human respiratory activities started during SARS-1 in 2003. Until that point, I'm a physicist, and until that point, I was leading a unit focused on particles, airborne particles from all kinds of sources, but not specifically from human respiratory activities. In 2003, I was invited by the WHO to join a team in Hong Kong to explain the reasons for an outbreak there in Amoy Gardens. WHO had a team of epidemiologists which wasn't able to answer this problem. And the hope was that aerosol experts would be able to do this. This mission didn't take place because by that stage evidence wasn't there. But I started looking into this and realized that in the past 60 years, there were only 3 papers on physics of particles from human respiratory activities. So I thought, wow, that's amazing. For a physicist, these are still particles, so it just made sense to include this in the portfolio of our research activities. We applied for grants from the Australian Research Council, got money, and for the next many years investigated in many different ways particles from all our different respiratory activities. And I'd like to add here that we were doing this as an interdisciplinary team, including medical colleagues. The idea was that we would also investigate virus in these particles, but it was too difficult because the instrumental issues, the concentrations were too small. So in time with our medical colleagues, we then shifted to also to bacteria, and in particular to Pseudomonas emitted from by people from with cystic fibrosis, mask and so on. It was quite really broad. So, but a few years into this, I thought, well, we have all this knowledge. Let's do something such that we can, well, in buildings, make sure that infection doesn't spread. So then we applied for grants, again, from the Australian Research Council, but it was impossible then to get those grants. The epidemic was over, and I vividly remember one comment from one of the reviewers of the grant: airborne transmission is not possible. Well, grant reviewers say all kinds of silly things. I never thought that it was something more systemic. And then came this pandemic, and I was watching with disbelief what was happening. People with gloves, but not with masks. And then seeing the statement from the WHO at the end of March that the virus is not airborne. Well, that was enough to me. We knew that it was airborne, and at least two members from the team, Jose and Hugo Lee, are here. So the next 3 months which followed were unreal. And our interactions with the WHO, which we've described later in a paper, COVID-19, science rejected, lives lost, can society do better? So then came, well, finally we published our open letter on the 6th of July, which I vividly remember. And the next day, WHO acknowledged the evidence emerging that the virus is airborne. Well, evidence wasn't emerging during this 3 months. Evidence was there. So, but what I wanted, so it was then what happened next few days, next week was again unreal with the focus on this. But an important point here is that after this, in the coming weeks and months, I received thousands of emails from experts from all kinds of areas of this interdisciplinary topic from every corner of the world. And many of them were medical doctors. And I can say there was not a single medical doctor who said that what we said wasn't true. So it led me to believe that it's not that the whole medical society, all medical doctors, reject this knowledge about airborne transmission. It is somehow that belief is within, well, that arm of the WHO and with public health departments in various governments. We had the same in Australia, and I experienced this in other countries. So this is why it is like this, that people who are responsible for public health rejected and still reject this science. This is something which I can't explain, but as I said, I'm convinced that it's not that the whole medical side, it is this specific areas.
Yes, thank you very much for your story. I think with this story, we already kind of entered into the discussion. It was not just an introduction, it was also an opener for everyone else. So next I would ask Mark Ongren to introduce himself and maybe take us a little bit further into the discussion. But let's keep these short so we can get to the topics because we have so little time. We have to keep moving. So please, Mark.
Sure. So just to be clear, do you want me to just kind of introduce myself, or shall I give a
You
bit
can
more of
introduce
where-
yourself and maybe like the previous panelist, you can just give us one piece of the mosaic very briefly, and then we can move on to the next person. Like
Okay, sure.
your top most important story that you can tell on this topic.
Sure.
Maybe.
Okay.
Yes.
Yeah, so Mark Hungren, University of Calgary. My background is biomedical research, interdisciplinary academic work in pharma for a while, etc. And my focus has been on translation of biomedical research into effective change. And a chunk of that has lately come up is around the issues of scientific rigor, research integrity, and just bigger picture philosophy of science questions. I mean, I guess maybe we could go on to Dr. Tomlinson intro, and then I
Sure,
can.
let's do that, and then let's
Sure.
come back to that topic.
Thanks so
Please.
much, and really honored to be invited. And I'm overlapping a lot with others that have spoken already, but I'm a complete idiot. Nobody just came to this with no prior background of any importance. But since the many years of involvement with this, I've realised that through disclosures to the UK COVID-19 public inquiry, have recognised that it's clear that leaders in the World Health Organization had the evidence that transmission was via the airborne route, importantly, out with aerosol generating procedures. So David Heyman, in his witness statement to the first module back in October 2023, he kind of led on the SARS response. He just casually drops out that, they knew from epidemiological data in January. He mentions the lovely study of the two buses, the pilgrimage with one asymptomatic pilgrim in one bus, and how no one in that bus got infected who was sat by an open window, and no one in the other bus got infected at all. That has also been affirmed from the UK. Is a really weird sub-study of this now, how science advances fail to get translated into useful policy. So the CMOs, the CMO and the Chief Scientific Advisor released a technical summary of the pandemic in 2022. And again, they casually trot out that they had the epidemiological evidence in January 2020 that airborne transmission was important. No mention of aerosol generating procedures, of course, they knew it was important in real world situations. So I'll perhaps sort of end there as a way of facilitating further discussion.
Our first 15 minutes, by the way, are already almost up, so we really have to. I'm sorry, I'm like so traumatized from the first session, how quickly it was over. So before we go on, I would like to throw at you a few.
Mark hasn't had a chance to give his opening statement, though. He only introduced himself.
Mark, yes. Maybe your opening statement, and then I will throw at you some topics so we can pick out what.
So yeah, I'll chuck out an idea for I think, in the spirit of the kind of the convening to maybe trigger some discussion now and as we go on. And I'm happy to hear from people, afterwards as well, because this is still something I'm thinking through the implications of. But yeah, so there's a temptation to focus on individuals, bad decisions, bad people, and obviously there have been both, right? But in the bigger picture, those are predictable components of the system that we're dealing with, right? There's always going to be bad people. There's always going to be people making bad decisions. That the system that makes these critically important decisions is so brittle that it fails in the presence of predictable challenges. And it is a systems level problem, right? Like University of British Columbia has been teaching droplet dogma in their PPE training up until 2024, and they only stopped because I reached out to them. And so it's not surprising there are individuals who are out of date and out of touch with the science, because that's what's being taught in UBC is one of Canada's top medical schools.
Absolutely.
So I guess to my mind, and the position I've kind of evolved towards over the last few years is the actual decision making, that this idea of evidence-based medicine as opposed to a science-based decision making process. And so I'm going to argue that EBM is not science. It engages with science. It's adjacent, but it is a policy on taking shortcuts. It's a heuristic, and originally developed for frontline clinical decisions in timescales measured in minutes and hours, where time, resources, expertise are not available for a deep dive into the science, right? The quick and dirty, something needs to be decided now, rather than deciding a week later,
Yes,
oh, we should have
that's
done
what
this
we-
other thing.
That's exactly.
And so if you look at that, like, so what is the key difference between that decision-making process and a scientific approach? And I think it's what happens when discordant evidence is encountered. So in science, when we encounter discordant evidence, we focus on reconciling it, right? It's all gathered from the same universe. And so, necessarily it has to be compatible. Now, maybe our theoretical model needs improving. Maybe there's an error in how some of the science was carried out and how some of the data was collected. But fundamentally, there has to be an explanation somewhere for why this method produced this result and this other method produced a different result. In contrast, when evidence-based medicine encounters discordant evidence, the general approach is either averaging it or choosing between. So in EBM, there's very little value placed on understanding why the discordance exists, and that the process just wants to deal with the discordance as quickly as possible and move on. And that's understandable in a process that grew out of that frontline decision-making process, that need for urgency. But at the larger scale, it means that errors are missed, decisions fall back onto these arbitrary rankings, like an RCT is gold standard, regardless of whether it was well or poorly conducted. And then really just the collective biases of the team, right? They'll look and say, this is a high quality, this is low quality, high risk of bias, low risk of bias, but those aren't objective decisions. And so, or, and then alternatively, the things might just be dumped into a bucket, right? So rather than cherry picking, the good and the bad's all mixed together and stirred up into a mush. And that's kind of reflected with these phrases like no clear evidence, possible minor benefit. But everything just looks like it doesn't work. And so I think really what we need to do to fix this at a systems level is explicitly move away from the evidence-based medicine structure and for high-level decision-making back to this idea that decisions need to, that disparate evidence needs to be reconciled. And it doesn't mean that we have to wait until we have that reconciliation in place in order to make a decision. But it highlights where we have to make a decision and we still don't understand why this evidence says this and this evidence says that. And another advantage of that is that because of the way EBM picks cherries and doesn't value subject matter expertise in the picking of the cherries, there tends to be a lack of subject matter expertise. And so the assessment doesn't pick out errors where there's an N95 trial that, intermittent use or someone's wearing it on top of their head like a hat, or because, well, it's an RCT, it's magical. Whereas if you focus on reconciling this discordant evidence, it at least highlights that there's something there that you don't understand, that maybe you need people with that subject matter expertise to dig into these individual pieces of evidence and say, was this really well conducted? Was that one maybe not well conducted? So I'll kind of wrap up there, but my conclusion from all of this has been that, yeah, we need to explicitly move away from evidence-based medicine models at large scale, high impact decisions and really consciously return to a more rigorous scientific approach. But again, happy to hear different views on that.
Thank you very much, Mark. And thanks to Katie for temporarily muting me so that Mark got his chance to tell us this great story. Yes, before we go on, I would like to just throw out a few topics / questions. I think we have already touched a large amount of them, including things like RCTs, EBM, the overconfidence stemming from these shortcuts, right? Then we have also briefly mentioned a lack of interdisciplinary approach. I think that's also something that maybe some of you have something to add to. Then we have the influence of personalities of, popular figures who might not be the best scientists or the best experts, but they have a big following on social media or they have political connections and thus they have a big influence on things. Then we have the publishing process, scientific journals. What is the problem there? Why is bad research getting published? Why have there been so many retractions? What is the problem with this rapid but unreliable science, and the associated issues with trust in science, with data transparency. Then we have the politicization and miscommunication of science to the public. Then we have the institutional and peer review failures, as well as institutional protection of star researchers. Clinical translation challenges, and the institutional inertia, bureaucracy, and all these other hurdles that come into the way of science that are not science, but they are important to science. So this has just been a little brainstorming, suggestion session for me. Just a bunch of topics that maybe you haven't been thinking about, but maybe now you're thinking about. So with this, if you want me, I can repeat any of this, but I would like to again ask any of you three. Maybe we go back to Lydia Morawska, that hasn't not been talking for the longest time now, and maybe you give me your perspective on one of these topics that you think is the most influential.
One of the topics, I believe, is how this aspect is taught in medical schools. I vividly remember a situation that was quite a number of years ago, when we had a medical doctor part of our forum on air quality, and specifically indoor air quality. And he said something like this, that every medical student has to learn by heart what is in the textbook by Harrison. So everything which is in Harrison must be known. But if it's not in Harrison, it doesn't exist. And air quality was not in Harrison. What I've heard recently, airborne transmission is not in Harrison. So until this changes, until all medical students learn about airborne transmission, we will be facing this kind of situation for a very long time. So change in medical textbooks is very important in my view.
I agree.
Of course, I'm speaking from ignorance. I've never studied from medical textbooks as a physicist, but that's what I've learned from medical doctors.
Yes, I also had to study Harrison, so I can tell you it was a very big standard, and it is something. Yes, we definitely need to look into how to change the education process. Maybe not just limited to textbooks, but also certifications and other aspects of medical education. I think that's very important. And maybe something I have to take a quick note about while I give the word over again to David Tomlinson.
Just a cause for hope on that. It's a really interesting example that you raised. So I got into a little conversation, if you like, with the editors of the chapter on COVID-19 from the Oxford Textbook of Medicine. I got a hold of an early release of the chapter via means that don't need to be mentioned, but one of the editors was my former boss, an infectious disease consultant in Oxford, Chris Conlon. So after about sort of 2 or 3 months of emailing and me providing progressively greater weight of evidence that his comment about transmission and the fact that the Public Health England guidelines were reasonable, i.e. for surgical masks, I was refuting all of those things in the strongest possible terms. It ended with him sort of giving me the brush off. And then 2 months later, without him telling me, the text was changed and he put everything I'd put in. So the Oxford Textbook of Medicine chapter on COVID-19 has the recommendation to use respiratory protective equipment. So little old me managed to kind of get that, but that wasn't what I was going to mainly mention. It was what Jode had suggested. So again, I got into a bit of a conversation with 3 institutions: University of Oxford, University of Calgary, and Imperial College London, over what I was suggesting to be actions amounting to research misconduct according to their own institution regulations. So this is Carl Hennigan, John Conley, and John Otter, respectively. So Hennigan and Chris and Connolly, it was the Airborne piece that they did as a part of a living systematic review process. So it's speaking to Mark's comment about it being a systems level problem and about how systems are very brittle in the face of predictable challenges. So it's predictable that you're going to get key opinion leaders who've got a vested interest in certain narratives and don't want reality to change. So I, over many, many months with these organisations, University of Oxford longer than Calgary, got nowhere. Up to and including the research governance lead in Oxford Uni and the Vice Chancellor. Possibly got my children blackballed from ever going to those universities, but what the heck. And the Imperial was hilarious. So John Otter was someone that wrote a piece with Didier Pitte back in June 2020, stating that the recent media releases that COVID-19 was airborne amounted to misinformation. Well, in April of 2020, he'd been collecting air samples from 8 hospitals in London, which proved that it was airborne. So his own research from April that he later published in June was already showing that there was RNA in the air, and yet he was able to put a piece out in June saying it was misinformation. So I'll leave it there, but I agree with the system.
Very sorry to interrupt, but we are at the 5-minute warning, so I have to give the word over to the audience. Please, I think Jose has a question or a comment.
Just very quickly reacting to something Lydia said in both of her interventions, it's indeed seems to be the case that the medical school textbooks don't have airborne transmission, but I had the same experience that she mentioned, that the regular medical doctors had no problem with that. And they all accepted airborne transmission, and they were reaching out to me, how do I protect myself? How do I protect my patients? So it doesn't seem to be the textbooks per se, it's the people in the infection control profession or public health. Do those, and I don't think it's they take the textbooks more seriously, but maybe it's more about the consequences of their actions and what the hospitals will have to do. And I don't know if the panel may want to comment on that.
Okay, I think we have another comment from, let's see, a lot of people. Greta Fox, Ubaka Okbogu, if I pronounced that correctly, and Clive Beggs. So I don't know who was first. And Sunil. Okay. All right, maybe let's start with Sunil because he's one of the organizers.
No, it's absolutely fine. I will be very short. I think there was a question about public health, and because I teach and train in public health, the problem with the public health is across the world, it's very theoretical. It doesn't have that implementation value built in it. So you don't take them to the practice. So what we teach in the books, we don't generally practice it and feel how exactly will it translate. So that's a problem with the public health that I generally feel around our times.
Thank you. Then let's go to, let's see who's next. Clive Beggs, is it?
Yeah, this is just following on really from what Mark was saying. One of the things that, and from what Lydia was saying, what I find, having worked with an awful lot of clinicians over a long, long period of time in various areas of medicine, what I find is that they're not necessarily understanding from first principles in any way what these things are. They've learnt them out of textbooks, or they've learnt what they've been told. So they don't have a full appreciation of what's going on. And then it comes on to Mark's point. So when you do, for example, systematic reviews or even randomized controlled trials, and you're trying to decide interventions or decide things, they're often just categorized. So, for example, you might look at a study which had a pathetic air cleaner in the space that really would have made no difference because it was too small. And then you say, well, it had no effect because you don't understand what the intervention is. You don't understand the physics, basically, or the engineering. And so things get categorized. And in fact, things are complex. These are complex systems.
Absolutely.
And so we've got a kind of analog thing.
I'm very sorry to interrupt. We have only 1 minute left. Greta Fox, please.
Oh.
Right.
Joe,
Yes,
I'm
thank
just
you.
going to interrupt. Hi, it's Katie. Joe has motioned that we extend this session for 5 minutes. And I also,
thank you.
and I would also like to say that Ubaka Ogbogu I've
Yes.
tried to elevate him, but the system is not allowing me to. But
Oh,
if they have a comment, they can please unmute and you can call on them as needed.
okay. So maybe Greta, you can finish quickly and then we go to Ubaka, okay?
Perfect. I'll be very brief because I'm sure Jane Tomlinson is going to speak to this bit. I just want to caution not to underestimate the importance of nursing education. Nurses are not getting any education about airborne. I have never seen that word in any textbooks, either in my undergrad or graduate studies. And nurses tell me that they basically skim the emails that they get from administration with any updates to policies or procedures or alerts, and that's it. They skim the surface. They don't have time to go look under the hood. So they're just going by what they're told. They do not have the information. And nurses are the ones who are hands-on 24/7 with inpatients, hospital, as well as in outpatient settings.
Yes.
And we need to, keep that on the table. But again, Jane will, I'm sure, address that in more depth.
Thank you, Greta. Ubaka, hello.
Hi. So great discussion. Thank you very much. I have a lot of thoughts about this, but I'm just going to try and be very brief and quick. I think it's kind of interesting to talk about science, and I know, the science is now well understood, but we're talking about it in the present. And if you go back, a few years, and I take Lydia's point that this was already well known, but just not well translated or communicated enough for people to actually understand that it's the orthodoxy now. But I'm thinking about how we arrive at a point where it's become clear, and thinking about science without reflecting about it from all the perspectives of the tensions within science itself. And I think there's something missing from this discussion, a science and technology studies perspective, a social science perspective. In essence, I'm worried about how we're defining science, how we're thinking of science only as medical science, as if medical science will get us to public acceptance. I just want to note that caution, because the discussion on science is basically just a discussion about essentially certain kinds of science and medical science. And honestly, as somebody noted, scientists are not very good at communicating messages and then get political resonance.
Right.
And so to talk
This
about
is the
science,
interdisciplinary approach that we mentioned, right? And the science communication hurdles. So
yeah,
I'm
so I
sorry.
just want to note that science is broader than medical science, and
yes,
to get
I have
somewhere,
to
we need other
go
perspectives
back
on
to
science.
the panelists. I'm very sorry. I would love to hear from all the rest of the 47 of you, but we have to give a few final words to everyone. So let's go quickly. Lydia Maraska.
Well, there's no one quick solution and one pathway. We need to talk to every possible body. In Australia, we are doing this. We are talking to the CDC, who has accepted this, has published a report, but it will be a long way before it will penetrate down. But as I said, from all angles and all of us.
Absolutely. Thank you. Mark Ongren.
I guess one thing that is worth knowing, and maybe took a little while for me to recognize through the process of the pandemic, has been that the attitude towards mistakes is very different in medicine and in science. In science, I'm wrong all the time. My junior students will correct me on things. My junior students will go to conferences and ask difficult questions of very, very senior people.
It's not okay.
And then, yeah, I've had MD PhD students who've commented on when they underwent the transition from doing the PhD, where, as a junior master's student, they would go and they would ask questions of someone at a conference who's kind of one of those names you talk about when Nobel Prizes are talked about, hard questions. And then going from that to medical training, where they felt like questioning the word of someone who was 1 year senior to them in the training program, and they got looked at, why are you, and I think fundamentally that means that's a big part of the problem, is that the people that make the decisions are committed, and it's a very challenging question of making that scientific uncertainty map onto medical policy.
We have 1 more minute until the end with the extended 5 minutes. Please, David Tomlinson, let's close this.
No pressure. So I'm going to echo something that Angela said earlier, because it's so cool. So, and it speaks into what Mark's just said, is so if we could value the voice of newcomers more, who haven't got that anchoring, and who can innovate against the the culture setting existing modes of thought, then we'd get a long way forward a lot quicker.
Yes. Great. We're done. And just on time.
Thanks, everybody. We're going to try and keep the schedule. I want to give people a chance to take care of their biological and other needs. So we're going to take 10 minutes and we're going to meet right back here in 10 minutes. It's pretty clear that we could pretty much have a month-long conference rather than a two-day convening. But a lot of great ideas being bounced around. So I'm going to stay in this room, and you can chat with me or other people, and we'll meet back here in 10 minutes.
Thank you, Joe.
Okay, thank you, Joe. Maybe if someone still had a question or something about this two panels, maybe not my panel, but the other one, they can now take advantage of the time and ask or
We also
suggest.
important to recognize that this is just the setup for our small group sessions, which we're going to have lots of time for deep conversation. Jeff, I see your hands up. I'm sorry I put your hand down in the
No, that's all right. No matter. Mark, that's wonderful what you said. Again, I'm going to jump outside our conversation to point out that if you read Adam Smith, he clearly says that medical care does not belong in the free market. Oh my God, we have a couple of 100 years of ignoring that advice in the United States, especially with the people that believe in the free market for their own profit. And I would say that's analogous to the idea that evidence-based medicine is the wrong criteria to create validity in public health interventions. Insofar as a lot of public health interventions involve case studies, which is an N of 1, or epidemiology, which is circumstantial assessment, not controlled. And to exclude that kind of information, I mean, the N of 1 was the Princess Cruise Line, where people who never were exposed to COVID caught COVID through the passageways or whatever, so it had to be airborne. End of discussion in February 2020. But it was overruled because it wasn't, quote unquote, evidence-based medicine. And so I would think that you would put into your very sophisticated discussion the fact that evidence-based medicine is a highly constrained artificial thing for proving that penicillin works, but it doesn't work for many disease or public health processes.
Yeah, I mean, yeah, I agree entirely. I think there's a couple fundamental issues. One of them is that if you look at the hierarchy of evidence sort of thing, the pyramid of preferred methods, they're essentially all backwards looking. And so really you can't
What's your
decide.
quote? It's like driving the car forwards while
Oh,
looking through the rearview mirror. Was that
yeah,
am I getting that right?
yeah, I think I forget where I used that, but yeah, the idea was, yeah, if you painted over the windshield of the car and you're driving by, and if the highway's relatively straight and there's gentle curves, you can survive that way. But once you get into unpredictable terrain, you're going to go off the road. And I think that's what's happened in COVID,
It's a
is
great
that
metaphor.
if we only accept evidence as being, after the bodies have piled up and it's too late to do anything about it, then it's inevitable that we're going to react too late and too little. And I think the other part too is that, and I guess a challenge when talking about evidence-based medicine is that what EBM means has evolved a lot since it was first kind of posited, and has become more and more kind of top-down and authoritarian. And the last, I don't know, couple decades, I guess there's been added into the top end of it, this idea that systematic reviews and guidance from elsewhere are themselves a form of evidence. And so you get into these cognitive lobster traps where once you've convinced yourselves of something, the mistake you made yesterday is evidence that you should make the same mistake today, even if there's a growing body of actual evidence that says otherwise. I see Dr. Brasso has a hand up there.
Yes, thank you. And thank you for those comments about evidence-based medicine. What I want to know is, can we help the world replace evidence-based medicine with some other better mechanisms for making decisions? It's a good thing, I think, that we've made decisions. I mean, there's a lot of agreement, and there's a lot of agreement in the scientific world, a lot of the medical world, and certainly among the public, that there are diseases that are airborne, and they are broader than just COVID. But what you do with that information is the next problem. And we don't have any good systematic way of identifying which organism that has the potential for aerosol transmission and which does not. And why would you make that decision? And we lack a lot of epidemiologic evidence we lack evidence that's easy to point to or easy to call science. We have a lot of anecdotal information. And I think what this group could contribute to is figuring out what is it that replaces evidence-based medicine for making decisions about organisms and pathogens that moves us beyond this droplet airborne paradigm into something that understands simply transmission through the air, as I think the WHO and others have referred to it. What do you need? What's good evidence? What's bad evidence? And put aside evidence-based medicine for a little bit, and talk about the biological, physical evidence and information that's needed.
So, I mean, I guess I would say there's two levels to look at that, right? There's the granular level. What techniques do we use? Do we, PCR from aerosols and things like that? And then the bigger picture of how different categories of evidence are interfaced with one another. And that's where I would say to the best kind of mental model I've been able to come up with over the last few years is that it's that distinction between whether we reconcile discordant evidence or whether we pick and choose or just average it all into mush. And it really seems to me that the failings of EBM have been around the idea that we just pick, this says it's airborne, this says it isn't. We're going to pick this evidence and we're going to throw away the other evidence and ignore it. Whereas I think a scientific approach is to say, well, both of these, there's information here. Maybe one of them was poorly collected, maybe one of them was well collected, but we need to be able to understand right down to the details why they're different. And I think if we, at least what I would propose that we do in terms of replacing evidence-based medicine is go to this, back to basics, right? I mean, science is the kind of the classic evidence synthesis process, right? And say that we need to synthesize evidence based on reconciling the differences rather than just saying, oh, well, I like that one better. But I'm still kind of processing all the implications of that, but that's sort of where I see it going.
So I wrote an article with Rachel Jones a number of years ago about aerosol transmission that lays out, and others have picked up on this as well and published similarly, that there are really only 3 types of evidence that you need to suggest that something is going to be airborne. You need to demonstrate that it actually becomes aerosolized, that it exists and isn't alive in a respiratory particle, or in the case of things like norovirus, other body fluids. You need to demonstrate that it stays alive in the air for some period of time. That's not hard to demonstrate in the lab, very hard to demonstrate, or much harder to demonstrate in the real world, but not impossible with sampling. And then the third is that you need to be able to demonstrate that there is some target organ, tissue, whatever, that once there's entrance into the respiratory system, it can access. And it can be something in the respiratory system itself, cells or whatever, but it can also, there can be transport through the blood and via the GI tract into the body, which happens with COVID, of course. And so once you have those 3 elements and you demonstrate them, you simply should just say, this has a very strong evidence base for aerosol transmission and inhalation and move on from there.
I'm just going to interrupt and say we're going to start again in 1 minute.
Well, I'll just say this is a fantastic conversation. Mark, with regard to discordant resolution, I bring up the case of H. pylori. It's the person who doesn't fit into the let's mix everything up and come up with the average. It's the outsider who made that insight and was rejected initially, couldn't publish the paper, it was rejected. That's the way you get a Nobel Prize, and that's the way you advance medicine. The other thing I would point out that
Jeff, I'm going to interrupt because we need to restart the This is great. We're going to have lots of opportunities for chatting in the small groups, but I want to keep the schedule and I want to respect the half hour that we've given the next group. So welcome back, everybody. So obviously lots of niduses for precipitating conversation going on right now, and that's exactly what the intention of this is. So we are going to move on to our next panel discussion, which is the role of politics and social capital. I really do think we need to think outside, as I mentioned earlier, outside that one or two individuals. There are some systemic things that are happening that we need to account for. And so I'm excited to have Julia Wright back again as moderator, and our three special guests, Jessica Ophir, Ubaka Ogbogu, and Shuti Chu, speaking on this topic. So over to you, Julia.
Great, thank you, Joe. So in the interest of maximizing time for discussion, I'll just note that everyone's bio notes are in the convening package, so that we can go straight to our speakers' presentations. And I'm going to just follow the program still, so that would mean that Jessica is speaking first. Jessica, are you here? Excellent. You're muted.
No, I think it's an audio thing.
Oh, is it?
Her mute on, and her image is very. While you work on that, Jessica, why don't we move on to one of the other panelists?
Sure, Ubaka.
Okay, thank you. So I have prepared notes because I'm a law professor, and if you give me 5 minutes, I'll take 30. So I wanted to speak today about the normalization of neglect, which I think has become a major barrier to meaningful public health action, and how I might begin to confront it. So very early in the pandemic, there was a push to frame COVID-19 as endemic. This was not simply a scientific claim, as we all know. Endemicity can be scientific, but this wasn't a scientific claim. It was a political maneuver. Those of us in Alberta knew when they started with Dina Henshaw. It allowed governments and institutions to step back from responsibility while signaling to the public that a crisis was over. That framing has had lasting consequences, in my view. Over time, it has also helped to seed a kind of cultural resignation. I think what we're dealing with now largely is not just a logistical or economic resistance to public health measures, like accepting airborne transmission and doing something about it. I think it is something deeper, a widespread disinterest and indifference. And this is rooted actually in public attitude. I think the public mood has shifted. There is fatigue, certainly, but also a politically convenient apathy that has been reinforced by disinformation, politicized messaging, and the erosion of collective responsibility. And governments have actually translated that into social capital and political capital, which they are now using to ignore the pandemic. Beneath that apathy, I think there's something even more troubling. I've written about this. For those interested, I'm happy to share the paper. Tonight, it's a form of necropolitics, a politics of death. This is the idea, implicit or explicit, that disease only seriously threatens those who are already considered vulnerable and therefore expendable. I think this is a huge problem. Public health measures are dismissed as unnecessary because the people who still need them, disabled people, the elderly, the immune compromised, are framed as already doomed. The narrative has been quietly accepted by much of the able-bodied public. It is a brutal logic, and it is shaping policy. We often hear that the action is being stalled by economic concerns. However, in my view, the greater obstacle is political will, and political will is shaped by what the public will tolerate or what they've been persuaded to ignore. So if you take clean indoor air, for example, it is one of the most cost-effective ways to reduce airborne transmission. We know that. However, implementing these measures requires acknowledging that airborne risk is still with us. We've talked about it already. That acknowledgement is something many officials are keen to avoid. As a result, even low-cost, high-benefit interventions are sidelined. So what can we do? I think we need to build momentum from the ground up, starting not with those who need to be convinced, but with those who are already leading and who are already convinced. Efforts to re-engage political and cultural will should begin in communities where a culture of safety is deeply embedded and difficult to dislodge. That includes unionized workers who have fought for safe working conditions and who understand the stakes of exposure. It includes disabled communities who have consistently pushed for protections and whose lives are still heavily shared by the COVID-19 risk. It includes healthcare workers, educators, and elder care advocates, people on the front lines who have experienced neglect firsthand and who are still organizing for change. I think these communities are credible, informed, and already mobilized. They do not need awareness campaigns. They need support, resources, and amplification. I'll close by just highlighting New Brunswick's recent updates and enforcement of OHS Regulation 91-191, which illustrates this principle in action. Rather than introducing sweeping new legislation, the province embedded COVID-era ventilation standards into an existing regulatory framework that workers already recognize, trust, and defend. By enhancing enforceable workplace safety requirements, like mandating mechanical or natural ventilation thresholds, New Brunswick leveraged a culture of accountability already rooted in organized labor and frontline workplace health. I'll stop there for now.
All right, thank you. Jessica, if your system's working now?
I've switched devices, so I hope it is. You hear me now?
Yeah, excellent.
Great. My name is Jessica Ophir, and I'm a retired social psychologist who worked for many years in the field of health risk intervention, specifically on the psychosocial determinants of HIV risk reduction. My areas of interest include public health messaging, the effect of cognitive biases and heuristics on health-related behavior, and intervention construction and assessment. So I have a slightly different take from those of the people who've spoken before. And I do have mild expressive aphasia, so I'm using note cards, which is why I keep looking down. What people often want me to talk about is the cognitive biases underpinning COVID risk behavior, but in preparing for the panel, I asked myself what were the health psychology takeaways I most wanted people to have within 5 minutes. And I came up with 3 intervention basics. These are quickly, first, that risk mitigation, whether governmental, community, or individual level, should be guided by behavior change theory rather than a theoretical, as has often been the case during the pandemic. Second, that how you do messaging matters. And third, that risk mitigation intervention should always be subject to some sort of assessment process. Even outside of academia, we need to know what works and doesn't, and also why. So briefly, in terms of using theory to guide COVID risk mitigation efforts, the main theories typically underlying health risk interventions in some form or another are Fishbein and Eisen's theory of reasoned action and theory of planned behavior. And you don't need to know those names, but folks should know, and I think a lot of people don't, the general framework, which is that risk reduction decisions are based on multiple factors. These include first, information about what the problem, say COVID, is, why they should care and what they should do about it. Usually the information part of public health messaging is the easy part. But with regard to COVID, we've often gotten it wrong, inexplicably. The second factor to keep in mind is behavioral skills. Can individuals or organizations or institutions actually do what you're asking of them effectively? And do they think they can? That is, do they have perceived self-efficacy or perceived behavioral control? Do they have the skills as well as the resources? For example, do they know how to run an air purifier, including changing filters, for instance, or put on a respirator correctly? And what internal and external obstacles may get in the way of compliance? We haven't done a great job with skill building either. The third component of behavior change is where the major hangups usually are, and that's motivation to comply. That motivation hinges on 2 factors: individual attitudes, which are based on people's beliefs about what you're asking them to do and whether they should do it, and subjective norms, which are basically the mitigation beliefs, attitudes, and behavioral intentions of people who matter to your target population. Those folks might be in group members, or they might be trusted out group leaders, such as RFK Jr., unfortunately, in the United States right now. To date, we've done a terrible job motivating airborne risk reduction compliance. Finally, I just want to talk for a second about messaging using Harold Laswell's model of communication, which asks the really critical question, who says what to whom with what effect? Throughout the pandemic, we've done a pretty lousy job at tailoring mitigation messaging to specific audiences or populations, often with the result of really pissing those targets off. We haven't used the right messengers who need to be credible to the particular targets at hand, which means that those messengers need to be respected as experts to those specific people you're trying to reach with a specific message. Whether they're credible to us, whether we value their expertise doesn't matter if the target population doesn't care or doesn't appreciate it. They need to be perceived as trustworthy and they need to be liked. Generally, and especially in the politically polarized United States, they need to be in-group leaders. It's hard to envision us having done worse on that front or on tailoring COVID-related messages to particular groups of people based on our knowledge of their beliefs, motivation factors, behavioral skills, and compliance obstacles. And of course, where we have been successful in initiating some sort of behavior change, we generally haven't gone back, at least outside of academia and at the community level, to assess what worked and if a target population wasn't compliant or wasn't compliant over time, why. Sometimes what we think will affect behavior change simply doesn't, or it doesn't bring about sustained change or the specific change that we wanted. And in my opinion, we need more understanding of those issues moving forward. And in my opinion, we need more input from health psychologists and even marketing experts who are often also social psychologists. And to end, just as a freebie, if you want me to mention a cognitive bias, because people always seem to, the one to look out for in the United States right now is the just world phenomenon, which is basically the belief that people get what they deserve. And so by implication, there's no reason to try to mitigate their health risks and threats because if bad things happen, then it must have been for good reason. So that is sort of underpinning what RFK and his minions are pushing. They're pushing it like it's ivermectin right now, the just world thinking, and it's going to be very hard to combat.
Great, thank you very much. Over to you, Shuti.
Hi, nice to meet you. I'm based in Taipei, Taiwan, Asia. My background is diverse. I'm a professor of global health, a family physician, and public health official with nearly 15 years of practices, and also a civil society leader. Today I was asked to talk about culture, so I will talk about, yes, culture, so what? The interactions between culture and politics. And I will talk about 3 observations. One thing is what happened in Taiwan during SARS outbreak and COVID-19 regarding masking when we were supposed to have pro-masking culture. And second, how about Western countries? They were assumed to have anti-mask culture. Did they respond similarly to COVID-19 regarding masking and their outcome? And that's what could be done. So first, about Taiwan. During SARS, I was at the front line, and at that time, we never experienced any threat to the healthcare system, which might cause a devastating fatal outcome to our healthcare professionals. And we took the action to put on N95 masks, the Taipei city government. In our daily press conference, we wore N95 masks, and we ordered healthcare professionals in Taipei City to put on N95 masks, and also bus drivers, etc. However, that's so new, and we were blamed by our central government that we were causing the panic. And then during COVID-19, and again, as early as February 2020, our former president, who was actually the former mayor of Taipei City, he put on his mask while he did a praying ceremony in a temple during the Lunar New Year festival. And about 1/3 of our people already put on the mask when they heard of a new outbreak from China. However, again, the president at that time, she blamed the former president for making a wrong practice, which might cause public panic. And also some other words, including that only people who were sick need to put on the masks. And also some people said that might lead to shortage of the masks. Okay, so those are the 3 common sentences said to we who to us who advocate for masking. So even though our culture might appear to pro-masking, especially after SARS experiences, still our government during COVID-19, they did not directly go to promote or mandate universal masking. No. And instead, it was the others, including also the hospitals and local governments. They asked anyone who went to the hospital, and they asked hospital professionals to put on the masks. So you see, even in the pro-masking culture, the political decision might not be pro-masking. And second, during 2020 and 21, may I give Sweden and Norway as the 2 examples. They share similar culture, they share similar biology, geographic location, healthcare system, socioeconomic status, etc. However, so they should have similar culture, including pro or against masking. However, they made different political decisions. It turned out that in the first year, mortality from COVID-19 was only 1/10 in Norway, as compared to Sweden, 1/10 of Sweden. And the second year, it's 1/4 of Sweden. And actually, in terms of life expectancy, Norwegians, they lived even longer in 2020 as compared to pre-pandemic years. And so what can we do? So I think this information showed that, yes, culture is important, but including my experiences in non-communicable disease, I think first we need to know what exactly is the culture. We need to explore. We need to have evidence regarding the culture. Quite often, in my experiences, not only masking, but also the other things, when the public know, actually, usually they show pro-public health opinions or preference. And even if they show opinions against public health interventions, I think we can still try to change it by advocacy campaign and social marketing. And it's important to leverage the power of evidence, as you say, science, and also storytelling. And it's also important to get key persons on board to be more persuasive and more visible. And it's also important to embed some fun and affection beyond the very cold and hard sense. And in addition, sometimes culture was shaped after interventions or practices. We call it learning by doing. So influencing political decisions, engaging politicians is very important. And sometimes politicians just wouldn't listen. So sometimes we also need to influence people's political choice. Actually, in Taiwan, the chief commander of COVID-19, he ran the election campaign for mayorship of Taipei City, but he didn't succeed. And we influence public's political choices through reviewing what happened. There might be good things he has done, but also some mistakes or wrong decisions, which was not for public well-being. And so I think it's important to look at culture, but we also need to look at the interactions, the dynamics between people and the politics. Thank you.
Thank you very much. So we have 10 more minutes. So we've got time for discussion. Are there any? I see a hand up already. Jeffrey Gordon.
Just a general remark, a little brainstorm. Insofar as this discussion is carrying forward and promoted the idea of the importance of evidence-based medicine, I was thinking that EBM might be replaced by artificial intelligence, and the large language models that are used will be based on droplet transmission because there has been no paradigm shift. So the institutionalization of the droplet model is likely to be promoted by future AI dealing with this situation, which makes our job even more important.
Great, thank you. Marty Pack.
Hi, great discussion. Love this. I just want to briefly just say a few things. First, I've been embedded with the long COVID community since August of 2020. We have been screaming into the void for a very long time. And what we do lack, as Ubaka pointed out, is the resources. I strongly believe education, whether it's science or whether it is communicating that science to people, is desperately needed. And I did a basic survey. There really is a desire for the general population to understand COVID and what's happening. You know, they're given these little glimpses of what long COVID is and what that looks like. But there really needs to be that educational push via media out there. I know multiple social media influencers on TikTok and other media, which would be more than happy to help out. I also am in contact and collaborating with former HHS officials, and I see that it would be a huge overlap into what we're trying to do and then combating this new administration, right, and the tearing down of our political system. So that I just wanted to share that with you guys, and I look forward to collaborating and partnering and seeing what we can get done.
Thank you. I think Nicholas Bertram had his hand up. I'm not sure it's still up.
Yes, thank you. I wasn't sure.
Okay.
Thanks, Julia. Yeah, no, so I think on this topic also, there's this interplay, right, between public health, obviously influencing behavior, but also behavior of the public, but then public also influencing what public health is ready to adopt, right? So the question is that you have the public that's looking towards public health as to what exactly is the standard. But then similarly, you also have public health that is then going to establish measures that correspond to what the public is ready to accept, because there is that political component. So the question, is I remember during the emergency phase of the pandemic, there was always this discussion of, we had McKinsey that was consulting for many governments, and they're talking about risk appetite. So they were saying that one of their objectives was to change the risk appetite of the population. So what type of risk is the average person ready to accept on a daily basis? So they said that on the one hand, yes, there was, sort of implementing measures that would lower the overall risk of COVID. Then in addition was also changing how people approach risk. And therefore, by changing that approach, people are ready to accept risk that was different than pre-pandemic.
Great, thank you. Lydia?
I'll agree completely on the topic of AI influence, which I think Jeffrey mentioned. I was invited about a year ago to give a plenary presentation at an aerosol conference, and we agreed on the topic. It was airborne transmission and something. One-page abstract they wanted from plenary speakers, which I did. And then somebody said, why did you spend time writing this? Why wouldn't you ask AI to do this, which I never do because I think it's silly if we use AI instead of us thinking this. So I thought, I wonder what AI would write about this. And what AI wrote was completely wrong. Again, it was really in this old dogma. So I'm using this now as an example. If we use AI for something like this, it will get completely wrong.
Yeah, AI work much like EBM, as Mark was talking about, it averages out what's already out there. So if it's drawing on a corrupted pool of information, absolutely. Any further hands up?
Maybe we can go to the panelists and have them do some final thoughts.
Yeah. I just wanted to make sure there weren't any further hands up. Okay, so final thoughts, should we go in the order that we had people present? So Abaka first.
Okay, thank you. So, I think just listening to the conversation earlier today and to what my fellow panelists have said, I think there's a need to reframe public health as we seek to rebuild. I think the focus now should be on how we generate solidarity. I think the public is not really listening. And so you have to go to who among the public is listening and then try to generate solidarity and build from there. I think public health has not failed because we do not know what to do. It has failed because we have allowed ourselves to believe we no longer need to care. And I'm talking about the public as a whole. And this is the real challenge we have to face and overcome. And so we need an alignment between public policy and lived practice as a way to re-anchor things like air safety as a shared norm. I think it's a massive challenge. I don't actually think it's a scientific challenge, honestly, at this point. I think it's a social challenge. I think it's a political challenge. And I think, as somebody who also did vaccine history for my PhD, I understand that once something takes root, shifting it can be very difficult. And to shift it, you can have the science and be begging people to accept it. But until you actually start to move people towards it, you're not going to have much success. So how do we move people towards these messages will be the key challenge and the message I want to leave with the group.
Great, thank you. Jessica?
Two things briefly. First, I agree completely that you learn by doing in intervention, right? And so there have been studies in terms of pro-vaccine attitudes in France, for instance, that found that after additional childhood vaccinations were mandated, attitudes actually became in society more pro-vax. And so it's not always that behavior follows from attitude. Sometimes attitude follows behavior. And I think that that's an important point. The second thing, in terms of one of the comments, yes, in terms of what we ask a society to do or particular populations, you have to meet people where they are. But there's been a real issue during the pandemic to underestimate sort of what people are capable of doing. And it's led to a framing of reality based on what the expectation is people will accept, rather than trying to change what people will accept or modify those attitudes and beliefs based on what the reality actually is. And I think that that's actually been a significant and ongoing problem.
Great, thank you. And our last minute over to Shu T, please.
Thank you. First of all, culture exists not only among people, but also among politicians. So when we have neoliberal politicians, they wanted to show their respect for individual freedom, then we will have the problem. But there is the dynamic that we can work with people towards the political choice we would like to. Second, very important is that knowing is not doing. Quite often we think if people know, then people will do. No, in fact, no. So very important is to show people how to do. And so as I say, we just put on our masks and it's N95. And then people know, and they also do that. So, and we need to show how to do it and also to provide enabling conditions so that people can do it easily. Thank you.
Great, thank you very much. And thank you again for a wonderful panel. Thank you for everyone for the discussion. And we'll hand things over to Worker Safety Panel next.
Yes, I'll introduce our next group. Leading this or moderating this discussion is Sunil Raina from India. We have the speakers James Thomason from the NNU, Yvonne Curran from Scotland, and Lisa Brousseau, who is a occupational hygienist. Over to you, Dr. Raina.
Thanks, Joe, and good morning, good afternoon, and good evening, depending upon wherever you are. Straight away jump into it and start with Dr. Yvonne.
Sorry, was that start with me?
Dr. Yvonne, please.
Well, okay.
Yeah, so you can start it with Lisa or Jane, anybody who's ready.
No, it's okay. I misheard. So I had lots of thoughts about this, but I think my first way to sum it up was the cavalry never came for the healthcare workers. And we had lots of organizations that could have stepped in with regard to correcting guidance and chose not to. The focus was on ITU, but not the healthcare assistant who was caring for somebody in a place with poor ventilation, looking after somebody more infectious and really in trouble. When they got COVID, they were told they could have got it anywhere. When they got long COVID, they were told, sorry and goodbye. And the one that sticks with me is the doctor who said to me, Yvonne, if it wasn't for my dad, I would be on the street. And that kind of directs things. I think with regard to the guidance, and everything goes back to the guidance for me, there was a failure to prepare for failure. My example for that is, what would a failure of getting the mode of transmission wrong, what would it look like? How would it present? And it would present like Trish Greenhouse, 10 reasons that this is not spread by droplets. And we should have anticipated that, or that should have been in the framework for not just producing guidance, but what it's done. And I think it's worth remembering that WHO put a get out of jail free card on every single guideline they produce. Regardless of whether you follow this or not, we're taking no responsibility. But institutional guidance doesn't. And that's an important thing to remember. And maybe that's why they just haven't said, no, we're not wrong, because the consequences now, there is in Scotland now, they have said the dichotomy that was used was clearly inadequate. They've not done anything about it, but they've admitted they're wrong. But if they actually turn around and do what you have to do because you've said that, the checkbook gets opened and there's no money. I'm old enough, and I'm probably the oldest one here, to remember before 2009. So 2009 is when the WHO said it's all spread by hands. Everything is spread by hands. But before that, in the infection prevention and control, MRSA was in the air. We now know that norovirus and lots of other pathogens are in the air. So this is not just an era of droplets, and airborne dissemination as a means of getting about needs acknowledged. It's out of task, I suspect, for what we're doing here. But that evidence is there. And Lister was the first one to say, what's getting in and suppurating my wounds are organisms from the air. So I think we need a framework for errors, and pick one from 10, there's plenty about. With regard to getting it better, high reliability theory is brilliant. And two elements of that, deference to expertise. What would we have done if they had listened to those people knocking at the door? Deference to expertise and a preoccupation with failure is what is needed by people writing the guidance. And I have one comment. I asked AI of the 2011 guidelines this morning whether aerosol transmission was important, and it told me it was. So it might not do a recent literature, but it did it of the pandemic preparedness. I'll stop there.
Lisa, please.
Thank you. So I guess my primary message would be that occupational health and safety needs to be at the table, but it rarely is. And when I've been at the table in the last 25 years, regardless of the conversation, and I raised the issue that, you know, there's going to be the likelihood of aerosol transmission. In fact, it's probably the definition of a pandemic in most cases is that especially with the respiratory disease, that it's going to be inhalation is the problem. But if you go back to look at the US influenza pandemic plan, and I suggest that people look at that because we had a pandemic plan in the country, and the word airborne or aerosol or inhalation, those words do not show up anywhere in that plan. As much as health and safety was at the table during pandemic planning for influenza and pushing that message over and over again, inside and outside of the government, it never ended up there. The other piece that wasn't there, which is really key to health and safety, was the issue of workers. And yes, there's attention on healthcare, and that is the right place to put attention in the beginning of a pandemic because you don't want your healthcare system to fail. But there are so many other workers who matter in the context of a pandemic. And that became very clear, especially all the workers who cannot stay at home and work on Zoom. And that's all our essential workers who keep the country going. There is no mention of essential workers, of infrastructure, assurance, security, and all the other issues, manufacturing, in the influenza pandemic plan for the United States. I think that what we need is a pandemic plan for the world. And it needs to say explicitly that you should assume airborne transmission ahead of anything else and plan for that. And if you have to step back, it's easier. But if you have to step forward into aerosol transmission, it's hard to do. Thank you.
Jane, your take on it.
Hey, everyone. So I think what I would add to this discussion about worker health and safety and the science here is that really we saw healthcare employers and employers in other industries really ignore the science, actively suppress the science, actively fight the science on aerosol transmission with the COVID pandemic because it cut into their corporate profits. And I think that that is a dynamic that is really important to name explicitly because it impacts how we think about what is needed to actually shift the dialogue and shift the practice on this really important issue. I still run into employers who say, healthcare employers who say that COVID is droplet in the United States, even though everyone here like really should not be happening anymore. And I think we, I work for a union for National Nurses United. We're the largest labor union for registered nurses in the US. And our members really took on this fight and really understood that it was a fight about the science, right? When you think back to the beginning of the COVID pandemic, and there were situations where hospitals were locking up respirators, locking up PPE, refusing to give nurses access. It was in the storage closet. Nurses knew where it was, and they were expected to go into COVID patient rooms without a respirator. Even though they were available in the hospital, they were given to doctors, but not nurses, right? I think nurses really understood intimately that this was a fight about the science, right? And union nurses were able to take on that fight in their facilities. So, we have collective bargaining agreements across the country where nurses won really strong language on access to respirators, access to PPE, fit testing, a lot of other protections. Nurses fought to end reuse of single-use N95 FFRs. which I think would be standard practice in this country if it hadn't been for the union nurses taking on that fight. And we still see non-union employers in our surveys, and then you run national surveys, and we still see nurses reporting, about 20% of nurses reporting that they're expected to reuse single-use PPE, even still in 2024, 2025. And so, you know, as the pandemic has evolved, I think it's also important to recognize that the industry has moved this fight to different arenas. And I would love to talk about this more. I'll wrap up my initial comments. I would love to talk about this particular aspect a little bit more if there's time for it. But we've seen industry move this fight, right? This fight about the science, that's also a fight about their right to make money off of workers' lives, right? Really, that's what this is. They've moved it to different arenas. So if you've been following the fight at HICPAC, the CDC's Healthcare Infection Control Practices Advisory Committee, right? The hospital industry moved it there. HICPAC's now terminated. And we're seeing industry move that fight actually to like the whole public health sphere in the United States right now. We're seeing this fight about corporations' right to ignore the science and make money off of workers' lives on a whole broad scale, not just about aerosol transmission, not just about aerosol transmission, but about a lot of other impacts and public health topics. So I'll leave that there as my opening remarks.
Thanks, Jane. And I think great opening remarks. We have a talk on frameworks. We have a talk on the fact that there was an organized sector and unorganized sector. We didn't cater to the unorganized sectors, the manufacturing people, those who were doing the labor work or something like that. And we had the role of unions. Probably I open up to the audience. If you have any questions, comments from the audience, please feel free to talk. I think Joe has a question or a comment.
Yeah, this is very much a question. The reason why we elevated this to importance as a panel discussion is because I do feel like had the occupational health and safety system worked correctly, we wouldn't be having this problem. And so there seems to have been a failure in there. And I think, Jane, you recognize it, identified it as being probably profit driven. But yet I feel like there should have been, or maybe should be, safeguards to prevent employers from circumventing safety for not just hospital workers, but other workers. So I'm just wondering if the panelists can comment on where the failure was and how we correct that failure.
We take the comment now, or we take it at the end of it? We have that round.
I can briefly respond to that.
Fine.
You know, you need a regulation, and you need a regulatory agency. In the case of federal OSHA in the United States, there is no regulation you can point to for infectious disease. They tried to pass, a TB standard back in the 1990s. Huge pushback from healthcare organizations. We can do this ourselves. We can monitor ourselves. We can take care of ourselves. We can come up with guidelines, which CDC did eventually, for exposure to tuberculosis. And as far as they're concerned, they were done. That was airborne transmission taken care of, and we don't need an OSHA regulation. The only state in the United States that has anything that's useful is California with its aerosol transmissible disease standard. And that requires every hospital and healthcare organization to prepare an exposure control plan to identify tasks that could be exposed to pathogens, and says specifically that a novel pathogen must be considered an airborne pathogen. That's the default. In California, even though there was lots of pushback about whether or not it was aerosol transmissible, and there were a lot of cases and citations from Cal OSHA, some of which were successful, some of which may not have been. But that standard was useful because you could point to it and say, here's what the rules are, here's what you need to do. We don't have that standard anywhere else, and I don't think there is such a standard anywhere in the world that would say in the health and safety, from the health and safety perspective, this you need to treat infectious diseases as potentially airborne. So without that, OHS is marginalized and not really part of the public health decision making. Health and safety is often, if you'll look at public health agencies around the world, you will see health and safety, worker health and safety is usually either not there or is extremely small in comparison to all the other disciplines and decision makers. They're not at the table, so that's part of the problem.
We take it to other somebody else. Mark first, then Ubaka, and then we can go to Jeffrey. Mark, please.
Yeah, so I think touching on both what Lisa said and Yvonne said, and as well Ubaka's earlier comments in the previous session, one of the issues is around recognition of expertise, but also, I guess, legitimization of expertise. So in kind of developing my thinking about EBM and things, I've tried to engage with people that I might not necessarily agree with to get different perspectives. And I had a conversation with someone fairly senior in the EBM space about some of the things that went wrong in the pandemic. And he said, well, you know, even the experts got it wrong at the beginning. You know, they said it was droplet. And I was familiar with some of this stuff. And I said, well, I'm not sure, you know, and he said, no, John Conley said, and it struck me that in his mind, the expert on all of this at the beginning of the pandemic was John Conley. And so I think there's an additional layer of bias that we have to get past here, that no one outside this sort of narrow group of quote unquote experts has an opinion that has any value. And so, you know, we get Dr. Maraska being shouted down by somebody with a BSc from 1976 as their last science education. And the perception is that that's actually legitimate. So I think there's, you know, some change there that needs to happen, that you know, from Dr. Brasso's experience, right, being on these panels and not being listened to, that we need to really hammer home. And again, Dr. Obugu was talking about even outside, you know, I tend to think of science as being, you know, my kind of science, right? But he's correct in saying that there is a much broader, you know, the social sciences and a full breadth of expertise that needs to be engaged with this. I'll leave it at that.
Ubaka, please.
So
sure. Go ahead.
Oh, sorry, I can wait.
We can have it from the panelists first. Ivan, please.
I was going to say that infection prevention and control used to be about mechanistic evidence. How does this transmit? You know, there are all sorts of experiments done which showed, but when everyone went over to evidence-based medicine, that kind of mechanistic evidence was dismissed as just irrelevant. And even deductive reasoning, which is what Trish Greenhow has done in that wonderful paper. So we have a system for writing guidance which doesn't value the types of science which will tell us how things transmit. And that's separate. If we know how it's transmit, we've got another bit over here that's going to tell us how do we prevent that transmission, and then we can get on it. But the evidence-based guideline in the UK, it's SIGN and NICE, but they don't value how does it transmit as a question. I'll stop there.
Please.
So I want to respond to Joe's question about what really went wrong with occupational health and safety. And I'm focusing on Canada because I kind of understand this context a little bit more than other contexts. I think there's two reasons we can put on the table. I think the first is that even though Canada's occupational health and safety system, and most occupational health and safety systems, are grounded in legislation and enforced by professional bodies, the interpretation, enforcement, funding, and development of policy, all of these things are subject to political influence. It really depends on the government of the day. I mean, we know in Alberta that the UCP government rolled back worker protections put in place by the NDP government, including rules around health and safety committees. You know, we know that Doug Ford did similar kind of harm in Ontario, and we've seen in New Brunswick, as I mentioned, how a government that is more supportive of occupational health and safety is making changes So I think that's the first thing. Political influence does matter in that respect. So it's not really, the failure is in part attributable to what government you're dealing with. But the second thing is that I think unions have really been disarmed politically, I would say globally. I say what we're facing now is we don't have old labor anymore. And as somebody who was sort of raised and groomed in the sort of labor thinking, and who considers myself to be, staunchly labor, I think, whether a combination of privilege and the left moving in ways that I don't understand anymore, I think we're just facing labor unions that have been disarmed throughout and who don't really fight for these things anymore. So those are some thoughts about why that is happening. I still think it's a route towards success because it's a community that is steeped in and embedded in that culture, but it's not a community that is as receptive to those messages or is fighting for those messages in the way it used to anymore.
Jeffrey, please.
I just have to say, sorry, Sunil, you broke up, so I'm not sure exactly what you just said. I just wanted to respond to this.
I said, Jeffrey, please. I just wanted Jeffrey to speak. He has been waiting for some period of time.
Okay, I'm going to jump in and just respond to this last comment because I disagree vehemently about the claim that labor unions are not standing up for these issues. I work for a labor union that has really led the charge on standing up for these issues. And we had a lot of brothers and sisters throughout the labor movement who were in solidarity with us, working very hard to win recognition of aerosol transmission and to win airborne aerosol protections in their workplaces, ranging from healthcare to meat packing to manufacturing to transportation, really all across industry, and really engaged in the HICPAC fight. Like there's a lot of, labor unions really understand that this is a life or death issue for our members. So I just wanted to kind of correct the record on that one.
I have a query on that.
Can I just very quickly say that I wasn't?
We talked to Jeffrey. Listen to Jeffrey first.
Sorry, can I quickly say that was a misunderstanding?
We will get a lot of time for those things, but we listen to Jeffrey. So Jeffrey,
I wanted to also sort of correct the record. I didn't put the blame on labor. I just want to make that clear. I don't want to be quoted as having put the blame on labor. I think I was misunderstood. What I was saying is that political influence has disarmed them, not that labor unions are not. I'm not putting the blame on labor unions. I just want to make that clear.
Perfect. Jeffrey, please.
Oh, great comments, a great discussion. First, we should make it explicit with healthcare workers being in the center of the line of fire between capitalism and healthcare. That's where the rubber meets the road and the conflict gets the heaviest. It occurs to me that everybody in this discussion would learn a lot from the history of the fight against asbestos in the 1970s. It is well recounted in a series of articles in that famous medical journal called The New Yorker by Paul Broder. And in fact, England banned asbestos a good 10 years before the United States. One of the factors were that the main textbook of occupational health and safety was written by the company doctor at the Long Beach Naval Shipyard. So he said, don't laugh, that's the reality of public health in the world. And that's why I think this case study is crucially important because it applies to the situations today. We've learned nothing in 50 years. And that is a case study which is very educational. I would call it to your attention.
Thanks, Jeffrey. We have another 6 minutes left. We can have a comment from each one of you, but I just want you to reflect on these two things. You have a strong influence as far as unions are concerned. But there will be places where the unions won't have influence. The workers who are on the field, they don't have a union of it. Construction workers, people who work in the agriculture sector. How do we take care of those workers who don't have a union? One, two, we have the occupational safety and health measures framework there in some countries, but it is not the same across the world. How do we address that part of it? And we also have a question from Tybex. Before we have his question, we have his question first, and then we can have a minute or two from each one of you. Clive, please. A quick comment. You're muted. Please unmute yourself.
Yep. Hello, mine's a slightly different topic, but equally applicable to the workplace. It's to do with ventilation, because I know certainly in the UK, all the guidelines, the HCMs that kind of guidelines for ventilation are all based on the kind of dichotomy of whether it's airborne or not airborne. But the simple point is this: that when you're dealing with the perceived IPC guidelines basically dictate the standard of ventilation. But even if you manage to change those, you've got a problem that ventilation is kind of hardwired into hospitals, because it's something you can't change easily. Whether you've decided, it takes time, it's a lot of money to do that. So we really do need also to be looking at ways of supplementary ventilation and other things that we can get around some of these kind of things that are going to be difficult to do when they're actually to do with the infrastructure of the hospitals. So I just add that in.
True. Yeah, and that's where I was hitting. It's much easier to have those ventilation processes in place in good economies, wherein the money is there. But it will be difficult for implementing in my part of the world. Every hospital may not have that quality of ventilation. But that's besides the point. So we start again with Yvonne. The last 1-2 minutes of.
There was one thing I didn't mention. There's a great book called Good Strategy, Bad Strategy by a guy called Rummel. And he says in man-made disasters, the biggest failure is engineering overreach. And engineering overreach is the ways in which failures arise, and the consequences of these failures are greater than the system's ability to comprehend, analyze, and resolve. And I just think that was, massive engineering overreach within. Worth a read.
Lisa.
Yeah, the issue of ventilation is an important but an interesting but complicated one, I think. We're caught up a lot in what industrial hygienists or occupational hygienists call dilution ventilation discussions, air changes per hour or air per person or whatever metric you want to use, which is all well and good. And certainly the more air changes, the better to some point. But the big issue is the transmission occurs person to person inside of rooms. And the transmission of COVID is, I'm thinking how much of it was likely to have occurred at a distance through ventilation systems is actually pretty small, though we don't really know. But lots and lots of transmission inside of rooms. Dilution ventilation is not designed to prevent transmission of organisms from person to person inside of rooms. The well-mixed model does not actually exist in the real world. And to change ventilation is complicated. And clearly, we can't put everybody in a negative pressure isolation room, which still requires respirators anyway. But we do really need to rethink what I call, and others have called, sort of below the ceiling ventilation, which is local exhaust ventilation in the terminology of industrial hygienists. If you look in our ventilation manual published by ACGIH for the last 35 or 40 years, it very clearly says you don't try to use dilution ventilation to control the exposure to hazardous aerosols. It's impossible. It does not work. Aerosols do not respond easily to dilution ventilation. Fine for gases and vapors, as long as they're not too hazardous. But you need local exhaust ventilation, and that's what we use in manufacturing and other settings. We need to figure out how to incorporate that into hospital settings. And it's possible, it's doable, it's expensive, and it's complicated. But that is the focus that I think we need to be moving towards.
Last quick comment, Jane.
Yeah, so I think the question that you asked about how do we make sure that all workers are protected is an important one. It's one that at least the leadership at my union is always thinking about. And I think it ties back to Lisa's comments earlier about the importance of having a strong regulatory infrastructure and good enforcement, robust enforcement that's available not just to union workers, but to non-union workers as well. And I think the last comment that I would make in this panel is, I know this is an international audience, but there are a lot of folks here in the United States, and what happens in the US also impacts what happens in other countries. And right now, our ability to win any kind of regulatory protections around aerosol transmission is literally under attack. We are in the defensive fight of our lives right now when it comes to public health, when it comes to our ability to win anything on aerosol transmission moving forward. So I think my big call to action for this group, or caution to this group, in how you put things together on what's next, is that you have to confront the fact that if we do not win the fight right now to protect our democracy, nothing is going to happen on aerosol transmission science and recognition of that science. So, I think the corporations, the billionaires, the Trump administration, Elon Musk, and all their cronies are taking over our public care agencies right now. Sure, they're looking to gut Medicare, Medicaid, Social Security, but they're also gutting the CDC, they're gutting FDA, they're gutting OSHA. OSHA will be next. And they're also attacking respirators, right? You may not be following all the vagaries, but they fired all of the people working on respirator certification in the United States.
Yes, I do, Jane.
Sure.
Thanks a lot. It was a great discussion.
Sure.
We are short of time. And I know it's not easy. If it was easy, we won't be here. We would be sitting in our homes, not spending our evenings here. And it's not easy always. I give an example. When I started the program, my lights tapped off because of the fact that there was a dust storm. So things are more complex in real world than they actually appear to be. Thank you. Thanks all for a great discussion. Over to you, Joe.
All right, we're into our last panel, and I feel like there's been some thought stimulated, which is great. That's the whole purpose of this, is to stimulate thought. I believe the last comment was we need to protect democracy as part of the results of this conference. That may be maybe beyond our scope, but the sentiment is totally appreciated, because really it's the underpinnings of how we protect people is if we have a functioning democracy. And so I laugh because it keeps me from crying. So now we're into the last panel. This panel discussion is really about, are there ways of looking backwards at what's happened to help inform what we do going forward? And really, this is partly about accountability and partly about learning from the past. We've specifically chosen these three people because they've been involved in various forms of accountability and looking backwards. I'm going to quickly introduce them because I do think their background is important. Dr. Barry Jones is working and has been presenting at the UK inquiry, which in my mind, maybe because of my Western bias, has been the most effective inquiry, although it's going very slow and probably hasn't done any change. It's at least elevating some of the mistakes that were made. Andre Picard is a health columnist here in Canada who wrote a really important book on a very important inquiry in the past called the Creever Inquiry, which was involved in a tainted blood scandal with HIV and other viruses being transfused into people, and what went wrong and why that took so long to turn around. And Matt Oliver, huge admirer of Matt, he brings two different hats to this conversation: an Indigenous way of learning, as well as a long background in safety engineering and engineering analysis of failure. So maybe we'll start historically. We'll go Andre, Matt, and then Barry. So Andre, you have the floor.
Great. So as you heard, I'm a journalist. I've covered actually many inquiries, and I think the question here is a good one. What's the best way to look back on COVID and inform how we change things in the future? The Creever Inquiry is an example of one in Canada. There was a very large inquiry. It went on for actually years, cost tens of millions of dollars. I think what I've learned over covering many different kinds of inquiries is the more focused the question, the better. So I think COVID would be a very difficult inquiry to do because it risks going off in many directions. I think we're seeing that, a bit of that in the UK. It's also it gets very politically bogged down. There are often, we saw this in Creever and many other, there's often lawsuits that come and delay an inquiry. And I think we have to remember inquiries are often done to avoid political responsibility. It's just put this off. That's why the Creever inquiry happened. There's an election coming up, and the government doesn't want to talk about it. So we have to be conscious of why inquiries are called. And to me, the key is really to have a very narrow scope, have a very specific question, and look for actionable recommendations. So often what happens is the inquiries are very sweeping. They have 100 recommendations. The government cherry picks 1 or 2, and 98 of them get forgotten, usually the 98 most important ones. So I think we have to be careful. People I know have debated in Canada, should we have a COVID inquiry? My view is we should only have one if we're going to commit upfront to implementing the recommendations. Just doing this for an exercise in self-flagellation, I'm not sure is that useful. So I'll leave it there. I look forward to listening to the others.
Maybe I'll put it to Barry to counter that, and talk about how the UK has been successful and maybe not successful. Any learnings from that experience?
Well, I'd like to think that we will be successful. I can't tell you that we have been absolutely successful yet. And we had a choice. We could go down the route of either not having an inquiry, or we could do the Swedish version where their interim first report came out in the middle of 2020 and their final one in, I think, February 2022. So they hadn't even gone through the whole pandemic. We've chosen to do it differently in the UK. It was a bit of a fight to actually get agreement from the then government, but the bereaved families for justice pushed very, very hard. There was a groundswell of opinion within the country, within the public, that an inquiry was necessary because there were so many blatant problems. And it will take an enormous length of time, and it is going to cost a vast amount of money. Although, if you compare that amount of money with the amount we spent on PPE, 18 billion, of which 8 billion was wasted, or the economic hit, which was taken by us during the pandemic, is actually a very small amount of money. And if we're going to do it, we should do it properly. And I believe that we are doing a reasonably good job of trying to do it properly. The chair is a retired judge, a formidable lady. I wouldn't want to meet her on a dark night. And she is very independent. And I think the government has very little influence over what she actually can do. And the terms of reference, which were eventually agreed in June 2022, were a bit of a fight, but they were established. We have 10 different modules looking at different things, different questions. I was involved in module 1, which was preparedness, and module 3, which was the effect on healthcare workers. And I lead a multidisciplinary group of healthcare professionals. We were about 100,000 before the inquiry, about 65,000 now. But at one point, I actually led over 1 million healthcare workers meeting with the government. In module 1, we put in a witness statement, which has led directly to our inquiry, stating quite categorically in its report, it's the only report that's come out so far, that COVID is airborne. So yes, we have had a hit, we have had success. In module 3, we are not only a witness, but what's called a core participant. So we were allowed to see all of the data, all of the 17,000 documents and 250,000 pages of evidence, which, as you can imagine, is very far-reaching. And in other words, try to do it properly. The way the Module 3 was structured was that I followed one of our other attendees today, Professor Clive Beggs, who's already spoken, and he was employed as an expert witness, and he came down so firmly and clearly on the side of the airborne paradigm and the necessary mitigations that it made my job much easier the next day when I appeared on the stand, under oath, by the way. So there are illegal consequences for getting this wrong. We believe that our inquiry has firmly taken on board the airborne route. It deliberately set out to make, as it were, fools of some of the government people who said that it's droplet. In fact, some of them are still saying it. Our minister responsible in the UK is still saying in writing to us in the last month or so, it's droplet and we're following WHO guidance. We've written back to them and they've not replied yet. Now, the big problem, of course, is that the report won't come out until next year. The actual inquiry finishes in March 2026 and Module 3 report will come out just after that. So there are enormous delays. But then you can imagine trying to put together a report on 250,000 pages and 84 witnesses who've taken the stand, and also what's called every story matters. There are 57,000 stories so far, and there are some interim reports already available. I think we're doing it properly. It's very complicated, but finally, will it matter? The question Andre asked is very important. The previous government said that they would follow the guidelines, and indeed the current government is actually following the recommendations from Module 1. They are setting up preparedness academic facilities to actually make sure we are better prepared next time. Although if they follow the droplet paradigm, they'll end up down the same rabbit hole. So we hope that that won't happen. I'd like to think we are doing it properly. We've done our very best to influence it. And I think it is going the right way. And the last government and this current government are not going to get off lightly.
Thank you, Barry. And just to kind of reflect on both what you and Andre have said before we turn to Matt, we actually had an amazing, it was called the Campbell Commission after SARS-1, that essentially nailed all the high points. And if we had followed the Campbell Commission recommendations, the second SARS pandemic would have been much better managed. But as has been pointed out, if you don't follow the recommendations, you don't get any farther ahead. And I guess that's part of the reason why we're having this discussion and why Matt's perspective is important, because historically engineers have been much better at learning from the past, because it looks really bad when two bridges fall down for the same reason.
And I just had one more comment, following on from what Andrew said, that inquiries are often delayed by litigation. It's the other way around in the UK. We've got a lot of civil litigation in the pipeline, and it's all on hold until certainly Module 3 of our inquiry reports next year.
Off to you, Matt.
Thanks, Joe, and thanks to all the speakers so far. This is fascinating. So Matt Oliver, aerospace electrical engineer, spent a bunch of my life doing accident investigation and forensics. If I had any claim to fame, it's broadly assessing causation in complex systems from different perspectives like technical, legal, or medical. And I'm Red River Métis, which is one of Canada's 3 Indigenous populations. So early on in the pandemic, I realized local public health information was a mess. I spent a lot of time yelling at my monitor. I became an aerosol advocate when I started seeing in public health response failure modes that I'd studied in significant engineering failures like Challenger and Columbia, or a failure to figure out what comes after the only plan, like vaccines sterilizing immunity doesn't work as expected, or when being told by an infectious disease doc that my entire profession writ large produces only low quality mechanistic evidence. The one thing I wanted to touch on briefly is I found it helpful to look at the historic development of technical causation and accident analysis. It's because I can see much of that public health and infectious disease intervention model still based on what I'd consider early technical causation models. So 3 quick hops through the history of technical causation. In the 1930s, a gent named Heinrich developed an early scientific approach to causation in industry called the domino model. So for an accident to happen, each domino needed to fall and knock the next one. If you remove a domino, it stops the chain of causation or the accident chain. And his work set everyone on a course to eliminate human error to remove the bad eggs, as bad people caused most accidents, 88% in Heinrich's opinion. So this is a purely linear model. And it's hard not to think about hand-washing enforcement here. Transmission only happens because bad people are non-compliant with the rules about fomites. Next up broadly comes set of more complicated models, but they're still straight line causation. James Reason got some renewed fame in the pandemic because of the Swiss cheese image, which is actually part of his larger system safety model. And Reason's model is useful, but it doesn't effectively represent complex system behavior. I mean, the reality in a Swiss cheese model of barriers is that each slice of the cheese or barrier is actually simultaneously moving in 3 dimensions and even swapping positions in a complex reality. Now we speak of complex system nonlinear causation that includes feedback loops, control systems, and multiple independent paths of simultaneous interaction. We also see the introduction of Charles Perrow's idea of normal accidents, that failures in systems need to be anticipated as a normal part of complex system behavior. Failure is normal. Human error is normal. It needs to be designed in. One model developed by Nancy Levison at MIT, known as the System Theoretic Process Analysis, STPA, has demonstrated it's almost a mystical ability to detect previously undetected modes of failure in aerospace systems, things that the designers didn't anticipate. And there was one team used STPA to analyze national level responses to COVID in 2021, and they found 236 potentially unsafe interactions or misses in the national response system. So 236 places where there was a missing feedback loop or control system, and that gap created the possibility of things to slip through. So this idea of complex system behavior, something that's core to all of our disciplines, is needed to understand how to build resilient systems that can experience normal failures without collapsing, because failure is normal and needs to be incorporated into design. And just my final thought, one of the things I found early in the pandemic was reacting to a lot of the public health stuff with a real visceral rage. And it took me a little while to figure out it was because there were some pretty huge colonial overtones coming through in the whole, we're the only ones who understand this. You don't have the knowledge that we do. You need to just listen to us because we're the experts in this. So one of the things I try to bring in is Indigenous or specifically Métis cosmologies, one that reject those default colonial modes of thought. Now, in Indigenous discourse, if we were facing a huge issue, like, I don't know, a pandemic, our response would be to form a diverse community, something like this one, a community of broad knowledge and perspectives where power and control are not the primary mediators. In fact, we try to create flat space where everybody would have equal voice. And in Métis understanding, we'd say that it's only in community writ large that we bring together all the skills and perspectives needed to deal with really difficult challenges. Thanks.
All right. I don't see any hands up. But maybe what I'll do is I'll just bounce some questions off the panelists until such time as somebody wants to step in. One of the things that we've had, and I think it's been referenced multiple times so far, is that governments have had a tendency to create documents that support the decisions that they've made and have not been self-critical at all. We've had one in my province of Alberta. We've had one in British Columbia. I think Australia also had a very self-congratulatory report. How do we avoid, because who's testifying at an inquiry will determine what perspectives are brought forward. How do we avoid, or maybe I'll turn to Matt first. How do you avoid that within the engineering sphere where you just have somebody basically trying to do a cover up in essence?
Yeah, I didn't use the word interdisciplinary, but I'm a firm convert that anything interesting in life happens in interdisciplinary spaces. Like Charles Perrow, I mentioned, a sociologist. He and Diane Vaughan, another sociologist, I believe, did more to inform modern accident causation understanding than anybody in the engineering side did, because they were able to look at our systems in different ways. So I think the way we deal with that in engineering is that we're so interdisciplinary in most cases that it's hard to have unitary perspectives, because we rarely work in teams that are only one flavor of engineer. We always have groups of different types of engineers who all bring certain different perspectives and biases to the table, and it gets harder to spin a consistent message a misleading message, perhaps, when you have a broad set of perspectives that are the ones that are crafting that. And I'd say the second thing to that is also focusing more on the technical reality as opposed to what the messaging needs to say. If engineers have a fault, we tend to be more in the weeds, more technical, and that helps us stay away from trying to spin a message. I don't know if that answers your question, but
that's great. Barry, would you say that you said that the Chief Justice on your inquiry is a Spitfire? Would you say that her force of personality is keeping people from successfully spinning, or maybe the legal element of that? What do you think?
Oh, she's very good at exposing stupid statements on the part of government officials. And she's even held up a surgical mask and an FFP3 equivalent to your N95 and said, surely this is better than a surgical mask. And you're telling me there's no difference. She's actually very good at, she uses an expression herself, common sense. She's actually applying a lot of common sense. And she's very keen on the precautionary principle and playing safe. She doesn't take any nonsense from any of the witnesses, whether from the government or from, if you like, our side. So I think it's actually, and also she doesn't ask all the questions. It's our top lawyers who are interrogators, if you like, or inquisitors, and they are pretty sharp. Nobody gets off scot-free, believe me. I know I didn't.
Clive, I know you've been involved in the UK inquiry. Did you have a comment there? Oh,
yes, I think I've got the inside information here because I was, unlike Barry, I was actually their independent expert witness. So I was part of the inquiry, working with them for about a year beforehand. So I had a brief that was really extensive. So I saw, from my bit anyway, what was going on. And they approached me well over a year before the inquiry. And I basically said, you've not got a multidisciplinary approach, and that you need to be knowing how this infection is being transmitted, and you need this evidence. So you need to know it's airborne. And they were really, really positive about this. So far from being a cover-up, they are trying to expose. Justice Hallett, as Barry says, is really hot, and they're holding the authorities to account. What I was given a brief not just for COVID, but also for influenza. So I had the opportunity to put that forward and to look at all routes of transmission and all the epidemiological evidence going back to the year dot. Now, I may have missed something, but I had to go through that and put it out there. My testimony is 4.5 hours of it. Is all online, all on YouTube for people to watch. And my report, the really good thing about, I wanted to add this to Barry's evidence, the really good thing about the British one was that they decided that they were going to put the evidence out there as it went on, not wait for the last report. So my report's out there in several languages as well, I think even in Urdu and things like that. They wanted people to know about it, but Barry's is there, everyone's evidence is there. And it was far-reaching. And I would encourage people to look at this because the brief I was given was exhaustive, I should say. Kept me very busy for a year, put it that way.
We're going to do
quick. No evidence of a cover-up.
It wasn't a cover-up.
From Jeffrey and Narendra, and then we'll go back to the panelists for final comments, and then we're completing the morning. Go ahead, Jeffrey.
Well, first of all, I would say I did watch some of the UK inquiry on YouTube and was astonished by it because you couldn't have such a process in America that was so blunt and directed toward outcome and details. It was fascinating in an anthropological sense. Secondly, I would go back to my Venn diagrams and say we couldn't have such an inquiry in the United States because it would quickly devolve to a discussion focused only on the origin of the pandemic, which is the most contentious, politicized aspect of the whole thing, and nothing else could be explored in a public forum because of the interactions of the various Venn components.
Narendra.
Thank you. I'm a civil society representative in a way, we have seen that kind of, the direct interface of the people, the community, which is making with the multi stakeholders, where the community somewhere we need to drop now, or seriously or honestly start thinking in line with that, breaking the giver and receiver kind of relations instead of coming up as a partner together. And second, I think honestly we need to look into one area which we call the way we take the credit of the science success of the science. The same way we need to revisit and relook the failures of the science, or the in various domains. I mean, these are the 2 points I just wanted to make sense here. Thank you.
All right, we have 5 minutes left for the panelists to put their final thoughts out there. I'm going to go to Andre first, and then Barry, and then Matt. So Andre, you have the floor.
If we're going to have an inquiry, either a public inquiry or an expert panel, as has been done in the past, I think that two things are key, and I think Dr. Jones made this really clear. Whether it's Justice Creever, Baroness Hollett, these are people who the commission has to be fiercely independent of government, and they have to be led by people of unimpeachable character, really strong personalities who are not going to be swayed by the politics. So I think you have to set up the proper conditions for success. I think the UK, I like what the UK is doing, but it's going to take a long time. And it remains to be seen while governments will act. It was the same with Creever. It was very, very impactful, but it took a long time. And the governments that were in power never paid the price because they were long gone. So I think we have to realize the benefits, but also the limitations of doing these things.
Andre, we have a little bit of time. I just want to ask you, the government's never paid the price. I think that speaks a little bit to accountability, and whether these inquiries are meant to be an element of accountability to try and make sure that those people who made poor mistakes don't continue on making poor mistakes. Would you say that's an element, or is that outside of the role of an inquiry?
Well, I think it has to be focused on making things better in the future. Repercussions, I don't know, that's more in the political realm, I think.
Barry, I saw your hand go up, so your comments.
Well, David Tomlinson has put a comment in the chat that said that Baroness Hallett's got the power to take down some very powerful people who are still in post in the UK. I should point out that some have already been put on gardening leave, and one of the main bodies is actually being disbanded by the current government. So maybe we're going the right way. Matt was talking about multidisciplinary approaches. One of the things which my organization has pushed very hard for, with the British Medical Association, Royal College of Nursing, and many other professional bodies, is to have exactly that, a multidisciplinary approach. However, as stakeholders, we were completely ignored and rebuffed during the pandemic by the powers that be. And we've had a chance to have our voices heard during the pandemic. Not just CATA, but as I said, BMN, RCN, and others have really had a chance to put the boot in. I think I feel very pleased that we had that opportunity to speak, because we were banging our heads against a brick wall for nearly 3 or 4 years during the pandemic, getting platitudes back from government people saying, yeah, oh, we've reviewed the evidence. It's all fine. We don't need to change the guidance. The pathogen hasn't changed its mode of transmission. Don't worry about it. Surgical masks are fine. We've actually had our chance under oath in the inquiry to point out that they got it absolutely wrong. And we're very much supported by the bereaved Families for Justice and the vulnerable groups and the Black, Asian, minority ethnic groups and so on, which will interest Matt perhaps. So I think it is going to take a long time. It's going to cost a lot of money, but if we hadn't taken a long time, it wouldn't be much good. So we just got to wait. Oh, and the other thing is that we did ask for an interim statement, which would force the government to change the current IPC guidance, which is just rubbish, still based on AGPs in the UK. And unfortunately, Baroness Hallett has declined to do that. But I think she might come down in favour of that next year.
On the one hand, we're, as has been previously noted, we're still in a pandemic. On the other hand, it's worth knowing that this is a fight that we've been doing for about 10,000 years. And so, the best time to plant a tree is 20 years ago. The next best time is today. So anyways, Matt, to you, and I just point out that Nick has put in a note in the chat that in Canada, the Bhattacharya's and other nefarious people are trying to get their agenda forward in an inquiry. And so there may be dangers in walking down that path. Anyways, last word to you, Matt.
Thanks. Just comment that I find this convening so fundamentally hopeful because it's bringing all those broad perspectives together, even if we don't necessarily agree with everything everybody says. I was also reminded listening to a couple academics talk about what their secret to their success was, and they both laughed and said it was mostly due to luck, and nobody ever talks about the 10, 15 years of hard slogging they had to do before they sort of found their niche and ended up in the positions they're in now. And David Tomlinson's story, I think, highlighted that beautifully, that sometimes it's just a one-on-one discussion and a push in the right place, and you can actually achieve really lasting change. I find that as a great point of hope because it does seem so many times like we're flailing away, banging our heads against those brick walls, but to remember that it's often a discussion that you didn't think was going to happen with somebody you didn't expect to engage with that can have lasting change down the road. So thank you very much to everyone and for the invitation to be here.
All right, folks, it's the top of the hour, wherever you are. Thanks to our panel. Thanks to our panels, plural. I think really the purpose of this morning was to stimulate some thoughts. I feel like there's a lot of perspectives out there, and the next 2 half days are going to be really key in getting to know one another's strengths and weaknesses and thoughts. And maybe developing that plan forward. I do think biology is really important to acknowledge, which is the biology of going to the bathroom and feeding yourself. So that's what this next half hour is for. It's a short lunch break, but that's only because there's so many more discussions to be had. We will meet here in half an hour to kind of talk about the ground rules for going forward in these small group discussions. That'll be very brief, 5 minutes, and then we will be moving to the small group discussions. And thanks to Dr. Chu, who is needing to go to bed, which is very understandable. And it's I noticed we don't have a lot of our Australian people here, and I think that's understandable too. It's the middle of the night for them. Hopefully some of them will join this afternoon. This space will be kept open for chatting if people want to keep discussing, but please do take care of your biology first. Katie, can you, oh, there we go. That's what I want to do.
Barry, are you still there? Hi.
Yeah, I'm here.
I just wanted to give you some offline feedback. I saw the inquiry interview a gentleman who was of Oriental heritage, who was an anesthesiologist who went from hospital to hospital as a consultant support for failing UK systems during the acute phase of the pandemic. And during his testimony, he gave vibrant personal stories of systems failure. And in the middle of his testimony, started to cry. I thought
Yeah, Dr. Fong. Yeah, and he's an anesthesiologist. That's correct.
A most amazing experience, vicariously.
That was one of the most impactful appearances at the inquiry, and it's constantly mentioned because he really did show how painful all this was.
Yeah. So anyway, from a Yank, that's my distant observation, it's absolutely a marvelous public experience that's going
Well,
on.
we had two of our members are actually long COVID sufferers, and one of them is in a wheelchair, having had intracerebral thrombosis following her COVID, a third COVID or second COVID infection. And she was she had actually advised African countries on how to deal with Ebola and dealt with epidemics in the Philippines. She actually went to a hospital and said, I know this is airborne, please give me an FFP3 mask. And they said, get lost. And she's now in a wheelchair.
Oh, that's so
It's just
sad.
appalling. It's
But
just
it does
appalling.
raise the issue that, in a way, focusing on this session on masks and aerosols, looking forward, the complementary or supplementary problem is long COVID and disability, and even disability without long COVID, uh, vulnerability to infections and
Yes.
regular chronic
Yes.
diseases, which is now being buried, just like the aerosol situation is being buried. And it's totally analogous to the problem, the political economy problem that we're dealing with here. And in a forward-looking sense is probably more important than how we redefine the epidemiology of COVID.
Well, I think so. I mean, the consequences of ongoing COVID impacts, both from the acute economic hits that and schooling hits, and now the long COVID impact is just massive, and it's being denied. I liken it to the post World War II Nuremberg trials, which, if you remember, in 1940, you look old enough to remember as I do. We would have heard about them when we were young, and people just stopped being interested in 1948, and they just disappeared. And it seems to be human nature just not to want to discuss these things, which actually have an existential bearing on humanity and our civilization.
That's why I encourage looking at all the different Venn circles, one of which is human nature and its simplistic cognitive heuristics. But the fact is that the UK, speaking as someone from the bleachers, the UK inquiry is exemplary and very, 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 very valuable.
Well, I'm glad to hear you say that, because a lot of people have criticized it. And of course, any inquiry is going to be criticized for either doing too much, too little, having the wrong bias, one way or the other. I think ours is steering a pretty good course across the minefield, if you like. It's not an easy job. I mean, I disagree with Baroness Hallett that she should have agreed to an interim statement so that IPC guidance can change now. Because after all, we can only stop long COVID by stopping people getting COVID in the first place.
Well,
and at the
but her
moment, our
consideration,
guidance is still predicated on AGPs.
but that's the point of my comments, which is her considerations are not yours, and she may be looking over her shoulder and saying, if I stick a knife in their ribs interimly, there are going to be political consequences to my legitimacy. And so she may want to get through the whole process before she starts to try and make
Well,
changes.
she has an advantage, Jeff, because after all, it was a previous government that made the mistakes. Although I have to say that the current government is carrying them on. But the current government has no particular interest in undermining her ability to come to sensible conclusions. So in a way, she has an advantage.
Well, again, I will first acknowledge the privilege of being able to talk to you, because I have no real responsibilities like you do. But I think you have to expand this to take the American experience as educational, which is my perception is that there is a degree of difference between the Republican governments and the Democratic governments in the United States, but they're both abject failures in regard to public health, because
Well,
they're
the
both
same can be said of our two governments.
they're both controlled by business interests in one form.
Well, I'm interested in, yeah, I was listening to you. I don't recognize that as far as the UK is concerned, quite honestly. And you know, when people start talking about cost implications of PPE, I just point out that they found 18 billion pound, $20 billion in effect for PPE, which about 40% was wasted. There was no shortage of money. It was just it was just spent in the wrong places. And of course, some people did make a profit, and they're now they're likely to get their comeuppance in the inquiry, because the last module, or some 2 modules ago, really went into that in great detail, and they have been exposed. I don't think let me say that my role as chair of COVID Airborne Transmission Alliance is completely non-aligned politically. I have to stick to that, because I cannot speak for my member organizations on the political of my political views.
No, I understand that, but I think American politics is much more venial than UK politics in its own way, and essentially crude and obnoxious. But it does.
I would agree with that.
It does flavor what we call liberal or progressive. The Democratic Party is certainly part of the problem, and as structured now, not part of the solution. It's quite evident. But again, as it reflects on public health, both Republican and Democratic parties have been, what's the word, inattentive to either science or the public policy of it. And it isn't.
Well, maybe now that Trump's withdrawn from WHO, it'll give WHO a chance to actually get things right. I'd like to think so, but it probably won't. I can see Clive is listening in here.
Yeah, well, I'm very. I just heard
Clive's
you,
got
Barry.
strong views on this.
I just heard you. Yeah, well, just to put you in the picture, Barry and myself have just written a chapter in a book on airborne transmission and keeping the environment safe, and we agreed totally on the science, and we were doing this. But the difference was that Barry was basically from an activist background because of his work with Qatar, and I deliberately, and why I was involved in the UK inquiry was because I resisted any temptations to get involved in any activism at all. So I was seen as a completely neutral, a neutral person. I didn't have any social media profile or anything. And so while I totally applaud what Barry's been doing, I think I'd go with Barry that one of the things that I think as scientists and clinicians, we carry more weight when we let the science do the talking. So I try to, even if I absolutely agree totally with what someone is saying, I will still not step over that line, because airborne infection is not the only medical battle I've been involved in changing things. I've also been working in neurology for a long time with MS and other things there. And I can see that sometimes activists can be more harmful than helpful to the clinical community and to the scientific community. Barry is not that, by the way.
I've come from it. I am scientifically trained. I've got a doctorate as well. And, I always think about this from the scientific point of view and how it should be applied and where it's gone wrong. I suppose I'm an activist. I was an unwilling activist. I just happened to end up where I am because I was the only one who was retired.
Well, I'm not trying to label you that, Barry, but no, I mean, I was just trying to explain the point anyway. But that's it. So, Jeffrey, that's where we are in the UK anyway. But
it's so wonderful.
We're pretty much on the same page on this one anyway.
Well, let me add a third triangle to your discussion, which is I'm a family doctor, so I'm a frontline clinician. As an amateur sociologist, let me point out that one way I think physicians who treat sick people are able to have the audacity to fight disease is to have strong guidance behind them about what to do. So they get very attached to it, and they have to be attached to it to have the hubris to treat clinically sick people who are going to die if they fuck up. So doctors have rigid mindsets which carry their old science information past its due date and have trouble adopting new habits because they depend on this, the volumes of past experience and so-called wisdom to face their problems today. And if they deviate from that, they're taking a personal psychological risk.
I'll give
Could
you
I
an
just
example,
ask
actually. I can give you an
Yeah, go on.
example. Barry Hunt, who's actually on this talk, is the H. pylori man. I mean, he proved
Yeah.
it could cause infection by swallowing it himself and then biopsying his own stomach. The resistance to his new theory for duodenal ulcer formation was unbelievably difficult, and I was immediately persuaded by his arguments. Not all of us are rigid. Many of us like to think outside the box. Many of us are constantly challenging the accepted concepts of medical treatment and theory. Sorry, Clive.
I was just going to add one other point. I think it got lost in I asked it earlier on, but I don't think people realized it. When you actually look at the medical textbooks and say, if we look at the work I did in MS and neurology, when MS was first characterized, it was by cutting up bodies and looking at the postmortems and looking at the brain. When you look at and then looking at the symptoms that patients presented with, other patients presented with other symptoms. It went into the textbooks as certain categories, the same as airborne, droplet, handborne. It gets into the textbooks as a categorical thing. It was only in the late 1990s that we started to have MRI and actually could look into the brain and see how it's functioning, and in the early 2000s to see how it's functionally behaving and performing. Now, the problem is those categories, everyone's taught along those categories, but in fact, things are a spectrum. Things are much, much more complex. And so it's not just that people have to, as clinicians, you have to make bold decisions, but also things are very categorical according to how they're classified. That's what I observe, when in fact, physics and complex systems are complex.